Morning, everyone. I'm Debra Callender. The webinar starts really at 9:30, but I've started it so that whoever was waiting can just join. And then we'll begin with some opening remarks at 9:30, and then we'll head into the presentations themselves. So welcome to everyone. Welcome, Winsome. It's lovely to see you here so early.
Oh, good morning.
Welcome.
I was wondering if I'd be able to listen from this one.
Of course you can. Of course you
Okay.
can. I believe a couple of our panelists, we are all working therapists and you're working pharmacists, but
Yes, I.
quite a
Oh,
few of us will sit in. So feel free to remain for the full time. I'm happy to have you.
yes, but I'm pleased to be part of it, and I'm definitely working, and I'll be in and out. But I just thought I would try and listen to as much as I could, until my
Sure.
time. So total 12:30, right?
Yes, I believe you're at 12:30. Did I say 12:30 or 12:45? Let me just check Winsome. Just
Please.
so that I don't tell you rubbish. One second. Uh,
And I was on an interview yesterday with Vernon Darby, so I told him about it. It seemed like he knows about it, and he said he would have you on his show one of the time to talk. I said yes.
I'm
So be
happy to talk to anyone about dementia.
right. Um, he'll contact you, I guess.
No problem, Winsome. You're 12:15. You're scheduled for
Oh,
12:15.
well, good thing I spoke to you because I'm looking for 12. That was 12:15. Fine. Okay, no problem. I will
Thank
all the
you.
best with your symposium. And so, are you expecting persons from the Caribbean or any other speakers from the Caribbean? I didn't really get to look at everyone's
Most
bio.
of us are from the Caribbean, Jamaica, Barbados. We have
Okay.
another speaker from the UK, Kartheka Bogan, who
Okay.
she will talk about a piece of technology that she has created, a piece of cognitive technology that she's created.
Okay.
So, yep, it's just the five of us for right now. And then we have another set of talks in February, which will have another mix of, I actually have, I think, a Polish speaker, right?
Okay.
There and some other islands, Trinidad and Tobago and so on. So we are trying to make sure that it is really, as I said, talk for the region,
That's
not just, talk for Jamaica. But we know that the Caribbean has a very, very strong relationship and a lot of links with the United Kingdom, yes? So, and I
totally
myself was educated there for my master's. So we'll
right.
always have, we always welcome speakers from the United Kingdom because we have such a very strong and close relationship with the United Kingdom, and a lot of our standards, etc., are quite similar.
Right. Well, yes, that's true. Right. And then I was born there, so that's why I still have the accent lingering. But
I hear it. I hear it. But I
right.
know that you're an immediate past president of our pharmaceutical society, so I know you're every bit as Jamaican as me.
Thank thank you very much. I'm glad somebody said something like that instead of going on like I don't belong here,
Oh
you
no.
know?
Oh no, no. Oh
Yeah.
no, no. You're every bit as Jamaican as I am. I know that for sure.
Okay. All right. All right. So you take care. So later, and thank you for inviting me again. And I
Of
know I'll
course,
enjoy.
Winsome.
Yeah. All right. Yeah.
Thank you.
So,
Hang out as long as you want to.
yes, man. Guess what? When I'm joining them, I'm going to use my computer. So
Mm-hmm.
I'll just join, that
I'll
time again.
set it so that the host can join from as many devices as they like.
Okay, though. Okay.
The panelists, you guys can
Yeah.
join from as many devices as you like. Just in case you have some issue, you can just switch device.
Right. Okay, great. Thanks for that. All right.
You're
So all
welcome.
they say break a leg.
Since we have 20 people in the room, I'm just gonna wait 10 more minutes and then I'm gonna start because we're scheduled to start at 9:30. But I opened the room early so that
Okay.
people could begin to come in.
Yes, man. All right. So take care later.
Sure, I'm Winsome.
Yes, right. Yes. Bye. Right. Bye.
Remember to mute your mic.
Yes. 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 I'm sorry.
So hello everyone who is coming into the room. This is Debbie Callender. I will be your host for the day and your first presenter. The webinar is really scheduled to start at 9:30. I was having a little dialogue with one of our panelists, Dr. Winsome Christie, who will speak at 12:15 and has come to hang out with us early. You all are very welcome, and we will start in 9 minutes with a few opening remarks, and then we'll get right into my talk on non-pharmacological interventions for dementia. Let me just summarize really quickly. Please, everyone, let me know if you can hear me. I think you would have to stick that in the question, and well, you can stick that in the chat. If you can let me know if you can hear me in the chat. So you can just type, that you can hear me or you're hearing me clearly if you want to. Let's just run through the timetabling. So I'll make some opening remarks, and then by 10 to 10, we'll have started my talk, if not before, on non-pharmacological interventions. Sure, Winsome. Let me see if I can do that for you. Let's see. What I'll do is it's easier for me to send you the link, Winsome, on email. Sorry, we can hear you with the chat is disabled. What? The chat is disabled, how come? Sorry. I've changed it to everyone, so hopefully that addresses that issue. Winsome, I'm gonna email you the link because it'll be easier for me than to stick it in the chat right now. Let me just do that, and then I'll return to telling you about the agenda. So Winsome, you should have the link. Let me remove this. Okay, so returning to the agenda, as I said, you're welcome, Winsome. Someone just let me know that the chat is disabled, which I think I've enabled it. But if not, I apologize for that, and then just stick it in the question and answer because I'll be checking both of them. So returning to the running order for today. So as I said, my chat should start by 10 to 10. So just some opening comments with the housekeeping and stuff that I think it would be very, very good for us to do on Zoom so that everyone understands the rules, because webinars, which I'm sure you're all used to attending, are a little bit different than meetings. 10:15, we're on to Dr. Pusey, Melissa Pusey's presentation on the motor aspects of cognitive impairment. So we're going to be talking about things like falls. We have Alexia Blair at 10:45, who is our speech and language pathologist. And Alexia has a really great presentation, really talking broadly about speech therapist's role in the management of dementia, which I think it's really fascinating. It was interesting to me when I saw it last night. At 11:15 our time, which will be 5 a.m. her time, we should have Kartheka Bogan, who is coming out of the United Kingdom to speak to us. Hopefully Kartheka will be able to wake up. I'm very grateful for her for coming to this event. She has a wonderful piece of cognitive technology that's called Cosmos, and it is a way of, when I talk about non-pharmacological interventions, we'll talk about cognitive stimulating therapy. Kartheka has translated that into technology, which is really, really exciting. So she'll be talking about her digital solution for early dementias. Dr. Tanya Edwards joins us at 11:35 to talk about dementia in the emergency room. She is a geriatrician who also works in emergency rooms, most notably medical associate. And it is very important for the caregivers of people living with dementia to have a good idea of what you would want to know and also have on hand when you are going to interface with accident and emergency staff. And at 12:15, we have the lovely Dr. Winsome Christie. I'm very, very happy to have Winsome on board. Immediate past president, as I've said already, of the Pharmaceutical Society of Jamaica. A doctor of she's a naturopathic doctor, and she also is a clinical pharmacist, and she has a doctorate in nutrition, if my memory serves me. So Winsome is just gonna be, I'm sure you guys are gonna have a really, really great time with Winsome, especially in the question and answer section, because one of the things that I think is very culturally different about us in the West Indies, we are always very interested in the natural options and things that might not be strictly pharmaceutical, which in the case of dementia is very important, because we know those of us who might be caregivers and those of us who have to work with people living with dementia, we know unfortunately that a lot of the medications only have a very modest effect. And so we would want to also be free to discuss other options and other evidence. And Winsome might be a good person for, I get a lot of those questions, but my background is in physiotherapy. So Winsome might be an excellent person to direct those questions to. So we're coming up to 9:30. A little bit of housekeeping with Zoom. As I said, we want to put our questions and answers in the question and answer area. I will be checking the questions and for each speaker. Speakers will come at their time and they might have to leave. I'm very pleased that I have recruited a set of working therapists. So we all, including myself, are clinical practitioners. So I see patients both for dementia care and as a physiotherapist, and so do all of the other panelists. So they'll come, we'll have a 10-minute question and answer. I've left some space after each talk where you can either ask questions or you can go ahead and get a drink or walk around a little bit or get a break. And of course, everyone is free to come and go as they like. I tend to prefer to keep things as relaxed as possible. So we will have each talk, then we will have a minute gap after each talk where you can ask questions to the presenters, or you can take a break and then we'll come back and move on to the next talk. And as I said, all questions in question and answer. Hopefully you can access the chat and then you can you can let me know what your questions are, or if you have any comments, etc. There should be at the end of this a post-event questionnaire, post-attendee questionnaire. Please do fill it out. We are very interested in your feedback. This will constitute one of what's going to probably become a series of talks. We certainly have a second set that are tentatively scheduled for February, which will have a lot of things like dance therapy, aromatherapy. We have a nice palliative care practitioner in there and a general practitioner as well, and so on. So the talks in February as well. You will be, I'll let you give you a lot of advance notice. And as I said, we hope to make this one of a series of talks. So it's 9:30, and I'm going to just jump into my opening remarks, having done that bit of housekeeping. So for those of you who do not know me, which is probably most of the people in the room, my name is Debra Callender. I'm a registered physical therapist, and I am a dementia care specialist. I hold a master's in dementia studies from Brighton and Sussex Medical School. I'm a 2021 Chevening Scholar. And I came across dementia initially as a physiotherapist. And when I was treating these patients, what struck me is as a physiotherapist, we have a lot of tools in our toolkit, a lot of interventions that we can use. Someone asked what the expected stop time is. We should be finished by 1 o'clock today. So yes, we have a lot of tools that we can use. And when I was interfacing with these patients as a physical therapist, I had this feeling that there was a lot of things that I still didn't know about interfacing effectively and getting the best out of a patient who has dementia in addition, because dementia does have a motor component. We tend to think it's only Parkinsonism that has a motor component, but most subtypes, all subtypes in fact, do have a motor component, and a lot of the early signs of cognitive impairment, which is the precursor state to dementia, do show up as motor issues as well. So when I went and got my master's and returned to the space, I realized that there's really a lot to be done in this space. We have to educate our caregivers, who a lot of them are looking at a lot of research, and there's a gap, globally between research and effective, functional, practical solutions for caregivers, not just in our space in the Caribbean, but throughout the world. That's a common complaint in research. So in our space, there was a lot of awareness that needed to happen. It's one of the reasons why I want to run these talks. And also what needs to happen as well is practical applications for our setting. There is a lot of stuff about dementia out there. There's a lot of information that you can access or pay for, but very little of it, if any, is really, really focused on the Caribbean context. And we are a very particular population in a lot of ways. There are some general things that apply to us, and then there are some things that are very, very specific to the Caribbean region. And I felt in this space, we did have a lot of, even my particular school, BSMS, did have research happening in Jamaica, and Dr. Eldemar Shero, who is has done some wonderful, wonderful research that I will always be grateful to her for, because she really helped to illuminate that space. And there's some great research out of Latin America. And I was able actually to write my dissertation on non-pharmacological interventions in low and middle income countries. But there's still a lot that needs to be done in the space. Our doctors, some of them are very aware, some of them are not aware, some of them are still quite dismissive if patients go to them. Our caregivers, as I said, who experience the gap between reading research and the actual practical application. And also, the general cultural thing where we don't seem to have a lot of idea of what is normal aging and what is abnormal aging. Dementia is not normal aging, and that needs to be said, and that needs to be remembered. And we also need to work, all of us as communities, as individuals, we need to work on being more aware of what dementia is and detecting it. So when we talk about early detection of dementia, it's very easy to say, okay, well, the doctors need to do that. The psychiatrist and the neurologist, and you need to take your person to a doctor. You definitely do. You do need to carry the person to the GP and express your concern. But the thing with dementia is that it's very important to detect it early. And so we don't want to wait until the person is necessarily really, has been showing us odd behaviors or having a tremendous memory deficit for years. We would want to move as quickly as possible when we see the very first sign. Our doctors and our psychiatrists and neurologists and some of our GPs as well are equipped to screen for cognitive issues. Dr. Jackie Campbell, who is not able to attend today and will just speak at another one of our events, and several of our GPs that I'm aware of routinely screen over 65 for cognitive impairment. So it's very important when you're seeing the very, very first signs of stuff. Don't wait for it to develop, because what you lose, dementia is a progressive condition. What you lose, you're not going to regain. So what we want, and it's not going to be cured. Well, we'd love it to be cured, but as of my talking now, it is not a curable disease. So we do want to catch it as early as possible, do what we can to delay the progression of it, and that requires early detection. When it comes to the space that I'm talking about, we have an issue where as I said, there's not a lot of practical information on what to do with the person living with dementia. And it is a dramatic set of information to receive. To live with a person living with dementia requires a great deal of change on the part of the carers and the caregivers. The environment has a tremendous impact on a person living with dementia. And caregivers who oftentimes in our context are footing all of the bills themselves, might be trying to do all of the care themselves, are often really stretched for resources and very tired, and it's very difficult to hear that you have to sort of consider reworking an entire environment so that it gives the person living with dementia a sense of well-being, especially when you're grappling with things like raising a young family. A lot of my caregivers are raising families themselves and so on. And also grappling with caregivers, which in our space are, unfortunately, they live, there are a lot of challenges around the type of caregivers that we are seeing. They're not tech savvy, and it would be fantastic if they were able to be tech savvy, because there's a lot of intervention down to monitoring of medication that is actually available in apps on a smartphone. But the current caregiving population, certainly where I'm living in Jamaica, isn't very tech savvy, not very able to use these things, not at all on board with the idea of doing more for the patient than maybe just cooking, keeping them clean, which is a lot. That's a lot, and it's important. But a person living with dementia also requires stimulation. And the current caregivers have to be brought into the idea that they need to play games, they need to have conversations with the person living with dementia that they're taking care of, not just cook, clean, and basically leave them to sit by themselves all day. People living with dementia do require stimulation if we're going to help them to delay the progressive decline that they're going to be faced with. Another thing that's important to say about dementia, which I wanted to get in my opening remarks, because you will have some basic definition of dementia, etc. in the talk, but there are some things that do need to be said about dementia up front, and that I would want to say, and I say to every audience that I go to. One of the things that we need to say is that not every form of confusion is a dementia. So it is this is why early detection is very, very important as well, because when it comes to dementia, dementia is almost a diagnosis of exclusion. So it's very key that if someone living with you is displaying, signs of confusion, or disorientation or odd behavior, that you get that remediated and you need to take that person to a general practitioner or to some level of medical personnel so that they can find out what exactly is happening with that person. And that's important because not every, a lot of confusional states are reversible with the right treatment and medication. And there's a particular condition, Dr. Edwards will talk about it later, called delirium, in which if we need to act very quickly to reverse the effects of delirium so that the knock-on effect doesn't last over 2 years, it is entirely possible to have deficits stretching to 2 years or that are permanent when we have an episode of delirium. So we want to make sure that we are sure that what we have is dementia, or the person that we're living with or caring for. We want to be sure that what they have actually is a dementia. Very important to get a diagnosis, and to get a diagnosis that specifies what subtype of dementia it is. There are several subtypes of dementia. The most common: Alzheimer's, vascular dementia, frontotemporal dementia, Parkinson's, and Lewy body dementia, and mixed dementias. It is very important to know which one you are dealing with. And it's commonly said that Alzheimer's is 60 to 80% of dementias, but in the West Indies, in the Caribbean region, we seem to have a higher incidence of vascular dementias. So very important to know that, because vascular dementias, the underlying issues really have to do with what we call NCDs, non-communicable diseases. So managing our blood pressure, our blood sugar, etc., our non-communicable issues can contribute to decreased risk. Yeah. So because it is progressive, dementia is progressive and it's incurable, it is very important to act quickly. If we take nothing else from this opening remark, I would like you to take that. If there's any question, please, if you have any questions of, if you feel like you're losing your memory, if you feel like your coordination isn't what it used to be, if you're having a lot of falls, if you can't pay your bills as you used to, if you can't coordinate tasks as you used to, I really want to strongly encourage you to get that checked out as quickly as possible. One, because it might be reversible, and two, because if it isn't, and if it is really a dementia or a cognitive impairment, the sooner we know, the better, so that we can act in a lot of ways. That can help to delay it, but also can put our affairs in order so that we're not, it's just easier for everyone. It's important to know also that there is a lot that can be done for dementia, which is why I am having these series of talks. We do have non-pharmacological interventions. I run a support group that is online and is open to anyone who wants to join it. You can look on my social media, and you can WhatsApp me, and I'll add you to I'll send you a questionnaire and then add you to the support group. It's very important to know that if there is stuff that can be done for dementia. I would like everyone listening to me to consider educating themselves more about dementia. We are doing talks, but also it's good to read about what the condition is, what the several conditions are. Again, on my social media and possibly on the social media of the speakers who are here, you can find a lot of really, really useful information, background information on what dementia is, how to be dementia friendly, and so forth. And it's important to educate yourself, because particularly in the region that we live, where, as I said, vascular dementia is the most common type, which means that we're talking about people who have non-communicable diseases, which we have a high incidence of in the Caribbean, developing dementias. It is important to educate yourself, because in the future, and also to create a society that is dementia friendly, because in the future, you may be in need of a society that is dementia friendly. And even if you aren't, these people who are suffering with dementia do need an environment and a society that supports them. They're not crazy. They're communicating all the time in a different way. Their perception is impaired, and so they see things differently from the way that we might see them. But they are still a part of society, and they do need to be helped and made a part of, the society needs to become friendly towards them and to understand what dementia really is. So please, aside from this forum, which I'm super grateful that for everyone who is attending it, please try to educate yourself and continue to educate yourself about what dementia is and how you can help. Lastly, I would like to thank all of the speakers who are here, who have contributed. All of our speakers gave their time for nothing at all, for no recompense, because they also wanted to push this forward. So I would like to thank Alexa and Melissa and Winsome and Tanya, who have and Kartheka, who have given their time and been really, really generous in terms of their time and their knowledge, so that we can begin to get to grips with what we can do about dementia in a more practical way in this region. Okay, so that more or less concludes my, I think, very long opening remarks. But I hope that you did get some takeaway from that. Please get yourself checked out. Please learn about it so that you can detect it in yourself and you can detect it in others. Very important for us to know that a lot of these changes start probably in your 40s and so on. So by the time you're starting to show changes, it's the brain change. By the time you're starting to show symptoms like loss of memory and so on that we can see, your people living around you can see, it's already quite progressed as a pathology in the brain. So at that immediately, once as soon as you're beginning to see these changes or deficits or challenges, that you begin to get them checked out. And if your doctors are dismissive, seek a second opinion if you need to, so that you're sure that you are not actually someone who has a dementia and who is, going to have a progressive experience of decline that we could have managed and delayed for you had we known about it earlier. Okay, so I'm gonna leave off of my opening remarks. Welcome everyone again who is coming into the room. Thank you so much for attending this. We're gonna try to record this webinar so that we can also continue to share it and you can have access to it. I'm going to now move into my talk about non-pharmacological interventions for dementia. I'm gonna see if I can share my content. Welcome Alexia Blair, who is here as well, our speech and language pathologist. She's also come to hang out, which I'm totally grateful for. Although, as I've said, we're all working clinicians in this panel. So I'm happy for everyone who is able to turn up. There we go. I apologize for that. There's always some little technical thing with Zoom, isn't there? So let's see if we can bring up our PowerPoint. So I'm going to leave it on this screen because I don't want to have any more adventures with my PowerPoint that I've already had. So welcome. This is a talk on non-pharmacological interventions in dementia. And it needs to be said that this will just be an introduction. This is a very broad topic. When you see how many different things are classified as non-pharmacological interventions, you'll understand why I say that we also need to all feel free to read further and investigate when it comes to these when it comes to this topic. Okay, so moving forward from there, I'm gonna just welcome you briefly to this talk. And in this talk, we're going to be defining what non-pharmacological interventions or NPIs are. We're going to talk about the benefits of using them. We're going to talk about the what types of NPIs are available, what are excellent. And we're going to talk a little bit about how you can select an appropriate NPI or non-pharmacological intervention for usage. Okay? So before we get started, I'm gonna, and throughout this talk, you should be warned that this is gonna be a bit of an interactive talk. So think for yourselves, what do you think a non-pharmacological intervention is? And if you can think of 2 interventions that you think you might already know, feel free. You can list them in the chat or the Q&A, or you can just list them to yourselves on a piece of paper. At the end of the talk, we'll see whether you were right or not, and we'll move, because throughout this talk, there are going to be some question and answers, just warning everyone up front. So what are non-pharmacological interventions really? Basically, non-pharmacological interventions are techniques that manage disease without drugs. It should be said here that dementia is not the only condition that can be managed non-pharmacologically. There's a lot of evidence for the fact that, for example, exercise can manage hypertension without medication. Everyone, please don't go out and try that, because it requires consistent exercise on a daily basis. There are parameters for that. But I'm just making the point that there are many diseases and disease processes that can be managed with non-pharmacological means in addition to drugs. They are typically, I should also say, used alongside drugs to manage dementia at this point, and they are used to improve factors and symptoms that impact our people living with dementia. Another name for them is psychosocial interventions, and in the United Kingdom, the NICE guidelines, which is the institute that governs medical practice, basically, in the United Kingdom, the National Institute, they have suggested non-pharmacological interventions as the first choice for the management of dementia symptoms. So that is to say, before we medicate, in fact, we should be selecting non-pharmacological interventions. Having said that, as I've said before, and will continue to say throughout this, we expect to use non-pharmacological interventions alongside medication. Okay? Welcome to Dr. Melissa Pusey. I see she's joined as well. She's another panelist. So, the symptoms that are managed by non-pharmacological interventions, the symptoms in dementia would be what we call BPSD, behavioral, sorry, I'm stumbling over my words, please forgive me. Behavioral and psychological symptoms of dementia, and BPSD covers a lot of growth. It can include things like agitation, aggression, depression, anxiety, hallucinations, delusions, and various behavioral changes that can manifest with the experience of dementia. They can be used to manage cognitive symptoms of dementia, and they can also be used to manage the physical and functional challenges that a person living with dementia can face. So another set of questions for you. What is another term for non-pharmacological interventions? Can you name 2 disease conditions that they might be used for? And can you name 4 dementia symptoms that they can be used for? Just giving you a whole lot back there. So why would we use non-pharmacological interventions? Because actually, when they're used appropriately, they're very, very effective. And that's been proven in research for the management of these symptoms we were just speaking about. But there are conditions for use. If you're using them appropriately, they should be started as early as possible, not at the point where the person living with dementia is in crisis, at which point they will definitely require medical assessment and possibly medication. They facilitate patient-centered care, and they are a very safe and effective option. And frankly, for many dementias, because there's a lot of medication for, say, Alzheimer's disease and possibly your mixed dementias, which are also very common. But for conditions like, say, frontotemporal and Lewy bodies and so on, that there are not a lot of options. So adding the non-pharmacological stuff can certainly help to ease symptoms, especially where you may be feeling that you really don't have a lot of other options, or the person may be feeling that. Now, the set of questions for you. Can you name 2 benefits of using non-pharmacological interventions? Can you tell us when they are not as effective in use? And do you know when they are most effective in use? I'm asking these questions throughout so that you can leave your answers in the chat or in the Q&A, but also so that you can just sort of check your learning. I prefer to help you to check your learning throughout the talk. So let's look a little bit at the types of non-pharmacological interventions. There are a wide variety. You can see things from dietary change, gardening, the use of animals and robots, music therapies, therapeutic touch, including massage, group therapy, reading, exercise interventions, physiotherapy, occupational and speech therapy, traditional and complementary medicine, and there are many, many more that can be found in research with varying levels of evidence. There is strong evidence for cognitive stimulating therapy, and CST, which I offer in Jamaica, is a combination of evidence-based interventions, including things like reminiscence therapy, music therapy, and lots of other different interventions that have been combined into a set of sessions that can be implemented with the person who living with dementia or in a group. Because of COVID in Jamaica and the correct and severe restrictions, because older people are more vulnerable, we haven't been able to mount group cognitive stimulating therapy as yet. But cognitive stimulating therapy, before we had the advent of donanemab, which is the newest Alzheimer's medication, was rated to be as effective as the medications used to treat dementia. Having said that, it should also be remembered that, as I said earlier, the medications used for dementia do tend to have a very modest effect. So always we're focused on sort of delaying progression as opposed to, improving dramatically anyone's cognition. Okay, which is why, as I said again, good to detect it as early as possible. So these things can be used in combination, so you don't have to just do music therapy or only use aromatherapy. You can combine the things together, and you can use them based on the person living with dementia's needs and preferences. Obviously, if someone isn't fond of lavender, perhaps you don't want to use aromatherapy or use another type of aromatherapy, another type of scent, as averse to trying to use it just because it's something that's listed as an intervention. It should be based on their needs, their preferences. It should be discontinued if it's not tolerated. You will have to and should experiment to find the right fit, because dementia is a very individual experience. And you should use it at least 6 months before you'll be able to assess effect. It can be continued indefinitely if it's tolerated and enjoyed by the person living with dementia. Now, the set of questions for you. Ready? Can you name 3 non-pharmacological interventions? And how would you select the interventions that you use? And how long should they be used for? So, summarizing, non-pharmacological interventions are basically non-drug interventions. They can also be called psychosocial interventions for dementia. They are recommended as first-line interventions, and they should be started early. They are safe, they are effective, And in some types of the subtypes of dementia, they really may be the only option, unfortunately. They manage all types of dementia symptoms, and there are a variety of options. And we should always be using these based on the tolerance of the person living with dementia. Last set of questions. Have you ever used, now that you know what they are, now that you've seen the talk, have you ever used any non-pharmacological interventions? I bet you have. Look at your answers from the welcome section. Did you learn anything new? I hope so. And what stood out for you? Thank you for listening to me today. I really appreciate it. All of my social media is listed below. I really encourage everybody to follow me on social media because a lot of information, in fact, all tips on various subtypes of dementia, any sort of other information is on my social media, my LinkedIn, my Instagram, my Facebook, my TikTok, etc. I do have a YouTube channel. I'm on Threads. I'm on what used to be Twitter and is now X. So you should be able to find me in some format that works for you. And I really encourage, because a lot of the information is there on social media and you can access it really easily without having to really interface with anyone. You can just look for what you need and get information you want, okay? So thanks for listening to me. I really appreciate it. I'm gonna stop my screen share now. And if anyone has any questions for me, you can let me know. I've wound up a little bit early. Not really, because not really. It's 1 minute past 10 and we should have a 10-minute question and answer, or 10-minute break where you can go and get a coffee or change your seating position or do something else. But if anyone has any questions for me, please put it in the Q&A so that I can answer them. Except for the panelists, of course, I think can just panelists can just turn on their mics if they have any questions on non-pharmacological stuff, or non-pharmacological intervention. Nice. I'm just chilling, waiting on questions. If anyone has any, feel free. I know I answered the question that I do see the question and answer, which is that we should be wrapping up here by 1 o'clock today. But feel free to ask questions. If not, feel free to use this time as a coffee break. We're gonna resume at 10:15 with Dr. Pusey's talk on the motor aspects of dementia, which is I'm really looking forward to this talk. She's a fellow physician. This is one of my best friends, and she is such a fantastic expert on any sort of motor impairment. She hails out of Barbados, and I'm really looking forward to Melissa's talk. So if there are no questions for me, which it doesn't seem that there are, oh, nice. Will this webinar be available after today? Yes, it will be available after today. I'm intend to make it accessible for everyone. How you will access it, I think I'll have you guys email, so I should be able to share it to you. I think it's afterwards they send a link of the recording once it's ready. You should get a link of the recording. How do you start introducing, Nicole, hi. How do you start introducing these new interventions without letting the patient know that you suspect dementia? I love this question. I love this question. This is a very common question. First of all, I'm not sure why it is you don't want the person to know that you suspect dementia. I think that's probably about the stigma around the word dementia. That's something that we probably need to discuss a bit. Another way I usually call dementia cognitive impairment because there's such a huge reaction to the word dementia. And also the people who are suffering from, increasing cognitive impairment can also be suffering from what we call anosognosia. It's this sort of not recognizing that something is going wrong. And it can get it can get a bit contentious in terms of you thinking, well, something's going wrong here, and them thinking nothing is wrong with me. So I totally get you, which is why I started to laugh. It's a fairly common situation. But I would still encourage you, Nicole, before I answer you, I would still encourage you to try and get that person diagnosed as quickly as possible. Because as I said, what you lose, you're not going to get back. It's not likely. So you want to delay it, and you want to catch them and try and preserve them at the earliest point that you catch them at. All interventions, Kartheka zone, my own, are much more effective the earlier we get to manage you, or we get to intervene with you. You can introduce a lot of those interventions simply by asking the person to participate with you. Basically, aromatherapy is as simple as putting diffusers in at home, right? I think what's important also, if you're dealing with someone who is becoming perhaps a little bit aggressive or a bit irritable with you, agitated, is to recognize that agitation and aggression oftentimes are signs of things like boredom and also signs of discomfort. So when you're introducing the new because that can be anything. As I said, so it's a broad set of stuff. I think taking someone to a physiotherapist or taking them to Alexa, the speech therapist, might be easier because you can say, well, you're having these challenges, you've had some falls, you are struggling to select words, etc. That might be easier to happen. Gardening, etc. You can do it yourself and introduce them, ask them to join you. Aromatherapist said you can just put it in the house and see how that works. But pay attention if they are very agitated and aggressive. Really, really pay attention to what's that environment like. And this is not something I'm saying in terms of blame. I want to be very, very clear. I want you to think, if they are saying or giving you signals that some things that never used to bother them before are now becoming distressing for them or unpleasant. A common example I use a lot is, some people with dementia, they don't like curtains because curtains can provoke hallucinations. Some of them find patterns difficult because for the same reason. Some people might be frustrated because they're trying to express themselves and they're not as good as they were before. You have to pay a little more attention and so on. So if you are having those experiences of agitation and also some of it can be boredom, so maybe seeing if you can make the time to do some activities. But you can introduce a lot of them really by just, saying, hey, I'm doing this. You wanna try doing this with me? There's a lot of evidence for things like singing songs or playing music. Music therapy is a very strong, lots of evidence for that. Exercise, hey, I'm going for a walk. Do you want to come? If they don't, can we play a 15-minute YouTube video? I do that with a lot of my clients so that we can sit in a chair and get some physical activity done. So you can introduce them without talking about dementia or saying, cognitive impairment even. You can try to just look at how you can make the environment more what the person says they want, and see what makes them happier out of the array that is there. If that didn't answer you adequately, feel free to type another question for me. I'm happy to answer. Liana, hi Liana. Liana's in my support group, one of my favorite people in the whole world. Great nurse, retired now, so no one can have the benefit of that except her lovely husband. She says a comment more than a question. Doctors seem to go straight to meds and very little mention of the others, and that is true. It does seem seems to be true in our context, but I will say in defense of the doctors. So when I came home and introduced myself, and for context, I've only been home for 8 months. I have to recognize it's not Dr. Professor Roger Gibson. I have to recognize him. Peter Gay Reynolds, I believe, is in the room. Hi, Peter Gay. Yes, I do check my attendance list, and you're very welcome. I have gotten quite a few referrals also from our general practitioners once I made them aware that I was here. I have gotten a lot of interest from some of them have been like, okay, great, we can send, because they do recognize, some of our doctors, that there's not a lot they don't really know what else there is to do. And I think it is as difficult for them in terms of sort of trying to offer people hope. But I've just gotten home. I've only been home for 8 months. So, hopefully that will change. But I have gotten from quite a few practitioners interest, and I have gotten referrals from some of our psychiatrists. So hopefully know that there are other options here and throughout the region, as they're about to find out. We'll see some changes there. But thanks for that, Liana, because it is something we'd like to have the balance between the medication and the interventions, definitely. Nicole says the knowledge will only cause them more stress. Nicole, you need to get a diagnosis. The knowledge I don't know that it will cause them more stress. I think actually I've had dementia patients say actually it was a relief when they finally figured out what on earth was wrong. And then the other layer to that, Nicole, is that it might not be a dementia. It might be something that is medicatable and manageable, and a lot of the confusion and behavior might go away. So it's not necessarily true that them knowing they have dementia may give them more stress. Sometimes it gives them relief, and it also frees you to do a lot of things, like put your affairs in order, because it can be very stressful in Jamaica where we live if you don't have things like a power of an attorney for people, etc. So it might there might be some initial fallout, but believe me when I say, particularly with dementia, the sooner you know, the better. And it might be a little stressful at first, but it's good to be present with them, and also to work through that with them in an honest way if it's possible. It's not necessarily going to cause them more stress. As I said, a lot of them have told me they were relieved when they found out. Yes, no, I know what you mean. Like Leona was talking about the fact that the doctors don't talk about non-pharmacological stuff. Audrey, hi Audrey. Audrey, are there any opportunities for group therapy in Jamaica? I wish. There is an opportunity for online groups, but online groups, because dementias do suffer also a bit with, I want to say suffer, but they do have the challenge with attention deficit. So online might not be as useful for them, but because of the COVID restrictions, which are very valid, older people are really vulnerable and can die, especially from the strains of COVID we still have in Jamaica. We are not able to mount group therapy live, which I would love to do in face-to-face, in person, because of the COVID restrictions that unfortunately have to remain in place. I mean, so many people I know have caught COVID just quite recently, and the severe variants are still very extant here, unfortunately. But even the non-severe variants, the ones that don't give you a lot of symptoms, I can tell you as a physio, they certainly have a very severe impact on your lungs, so particularly on your heart. So particularly an older person, I would not want to be the one who convenes a group and then someone in it is exposed to COVID, because it really has a horrible consequence for older people particularly. So we do have online groups. I can probably shoot you some stuff about that, and we can see if we can form a group. That would be nice, but it's just a little more difficult because of the attention challenge, but we can mount it. I had mounted some and it actually went quite well. And we can see if we can continue that. It just requires that the carers have to sort of be, around for that time as well, to just make sure that they're that they're still engaged with it, because cognitive stimulation should be enjoyable as well. It shouldn't just be like you have to do this. It should be fun. Nicole, thank you. Nicole says thank you, and to such a lot. I hope they did. Please check out my social media. You can WhatsApp me. You can look at that stuff. I'm happy to communicate about this, because it's really important. If you even suspect something's happening, we do need to address that as quickly as possible. So I'm going to close my question and answer, because I want to introduce my very, very good friend, Melissa Walcott Pusey. So Dr. Melissa Walcott Pusey, she has over 25 years of experience in physiotherapy and treating a variety of neurological conditions in both adults and children. I mentioned that Melissa is currently in Barbados. She heads Total Therapy Inc., which is a multidisciplinary wellness clinic there. And she's currently doing a neurological mentorship originating in the United States. I can also tell you, anyone watching, that Melissa used to work. I met Melissa when she used to work in Jamaica, and she was one of my clinical supervisors, and she had such a high standard. To this day, Melissa, I consider to be one of the best physiotherapists I've ever met, and I've certainly met a lot of them in the course of my career. I have about 20 years experience. She's an advocate of functional medicine and evidence-based practice. And Melissa is a graduate of the University of West Indies School of Physical Therapy, as am I, and she holds a doctorate in physiotherapy from Utica College in the United States. So please welcome Dr. Melissa Pusey. Melissa, thank you so much for being here. And Melissa is going to move her talk now. I'm going to mute my mic and let you get my mic and stop my video and let you get started, okay?
Sure. Let me just share my screen here with you guys. Okay, all right, so good morning, everybody. How's everybody feeling?
Melissa, can you hear me?
Yes, I can. You can hear me?
Can I ask you, I can hear you perfectly, but I'm gonna beg you just 1 second of your talk, because a last question came in, which is
Sure,
there an
go ahead.
online group for caregivers? Is there an online group for caregivers rather than people living with dementia? Yes, there is an online group for caregivers. It's on my social media. If you WhatsApp me, as I said, I'll send you a form, and then we can register you to the group, and you can attend meetings every 2 weeks. We have it on Thursdays. So it's there. Please look on my social media. And thanks, Melissa, for giving me that time to answer that question. And back to you now. Sorry about that.
No problem. All right. Hi, I'm Dr. Melissa Walcott Pusey, as Debra told you. I'm a physiotherapist working at Total Therapy Inc. in Barbados. And I'd just like to take this moment to thank Debra for inviting me to be part of this panel discussion, and to you, our viewers, for joining us as we discuss motor aspects of cognitive impairment in persons with dementia. So let's get started. I promise you, this is the only wall of text I'll be sharing with you guys today. Which is our definition of dementia. WHO states that dementia is a syndrome, usually of a chronic or progressive nature, in which there is deterioration in cognitive function that is beyond what is expected in normal aging. It affects memory, thinking, orientation, comprehension, calculation, learning, language, and judgment. Consciousness is not affected. The impairment of cognitive function is commonly accompanied and occasionally preceded by deterioration in emotional control, social behavior, and motivation. In the Caribbean, Alzheimer's is the most commonly diagnosed type of dementia. A lot of words, but what does that mean to us? So what we're talking about here is we're looking in the Caribbean at about 8% of our population has dementia. Women tend to be more affected than men, And Alzheimer's is the most frequent type seen in the Caribbean, which is then followed by vascular dementia. So on a one-to-one basis, we're talking about 52% of people who we know will know somebody who has dementia. 43% of people will have a family member with dementia. 17% will have a grandparent, while 13% will have a parent, which means more than likely we all know somebody and we will all be affected by this disease. All right. Now, I'm sure Debra talked a bit about this, but and we could probably be going through things that, you know, there'll be a number of repetition between our talks. But as you know, dementia is diagnosed by first by meeting up with your doctor and having a medical history. Now, the medical history is very important, and during this time, you need to say everything, even things that you don't necessarily think may be important, so that they can get a clearer picture of what's going on with you. Very often I find, you know, the patients will go to the doctor and then they'll come back to us and they'll say things and want us to explain it to them. And you're like, did you mention this to the doctor? And they're like, I didn't think it was important. But at this point, especially at this initial stage when we're trying to come up with a diagnosis, the more information you can give them, because remember, they can't read our minds, the better it is. Then they'll decide if you need to have a cognitive assessment, a functional assessment, maybe do some MRI, some imaging, some blood tests, so that they rule out anything else. As Debra said, it might not be dementia. And this is the point in time where we need to figure out what's happening. Dementia is a very progressive disease. And what happens here is you don't know people, it's very individualistic. So I will go through stages at different rates than somebody else will. Also, we should note that dementia is incurable and it is very life-limiting and life-changing. And because it is such a progressive disease, we try to retard or progress the progression of the disease, right? There are many different stages and there are different things that we're looking at in each stage. So let's just take a moment to go through the stages. In stage 1, it's pretty much normal. You're not noticing any deficits. We're not noticing anything at all. In stage 2, you start forgetting things. So you can't find the TV remote, can't find the cell phone, unable to find the car keys, unable to recall your loved ones. You see somebody and it might take you 3 dances before you can remember the person's name, or you look at them and you're like, I know you from somewhere, but where? In stage 3, the person might get lost while driving. So you'll get a phone call saying, boy, you know, I don't know where I am. Can you come get me? They forget things like birthdays and appointments. In stage 4, they start withdrawing socially because they know something is wrong and they're sort of afraid to interact with people and have them realize that there's something going on with them. They struggle with everyday tasks like tying shoelaces, cooking, deciding what to wear, combing your hair. You may come to pick them up and realize that the hair is not done. Simple things that were such a basic part of their life. Then you get to stage 5, which is usually marked by forgetting information and events. Sometimes you may see that they're wandering. I just want to say here that, you know, before this stage, or even when you start thinking that something like this may be going on, it's a good time to start looking into technologies, because there's nothing worse than having a parent or a family member who has left home and no one can find them. We start needing to think of things, you know, they now have so many jewelry that has little tracking devices in them. They have things on your phone, the apps on your phones. There are lots of things that we can utilize. And I truly believe that we just need to get out there, figure out which one works best for our family member or our loved one and utilize it. All right. Then we go back to stage 6. Stage 6 requires more assistance with the activities of daily living. It is at this stage that it becomes difficult for them to live at home, and the family members have to start thinking about things like, okay, are we going to have someone with them 24/7, or are we going to move back home? Are we going to have to start looking to put them somewhere? And if we are, we have to find an appropriate place. Hopefully, before this, we've done you've gone and figured out who is going to be able to make these decisions, who in the family is going to be able to decide, yes, we're putting them here, this is what we're going to do, and have started discussing these points. Right? At stage 7, their lack coordination, which is affecting their mobility significantly. Very often they may be limited to bed. And once you're limited to bed, you start having other things that making them prone to infection, prone to poor circulation, and those sorts of things. So the physiotherapist, what are we looking at? What are we going to be seeing in these patients, right? We are looking, according to WebMD, we're looking at things like loss of balance. We're going to be looking at things that the muscles are not working as they should. They're having difficulty with walking. Maybe may have a shuffling gait. They may be taking one step larger than the other. There are all sorts of gait deficits that we will be seeing. They have difficulty sitting from standing. This tends to be one of the first things that people will say to you, I all of a sudden I can't get up from these chairs. Why are these chairs so low? Weak muscles and easily fatigued. So a person who used to be able to go for a 20-minute walk will tell you, boy, I got halfway down the road and I had to sit down on a bench. Don't know what was going on. Or, I used to be able to cook the whole lunch on a Sunday, and now I find that I have to break it into, do something early in the morning and then get back to it. Right? Reduced fine motor skills. So you're having difficulty with writing, you're having difficulty buttoning your shirt, tying your laces, sometimes things like doing your hair, picking up fine beads, or if you're doing crochet or any of those things, difficulty manipulating those needles, trouble controlling your bladder and bowel, maybe difficulty with sleeping, maybe seizures and uncontrolled twitches. And remember that not every person goes through each and every one of these issues, right? So, and they don't necessarily go through them in this particular order, right? So what are the risks associated with these things? Because you're not moving as much, there will be increased risk of cognitive decline. You have decreased mobility and all the other issues that come with that, which we'll discuss more and more as we go on the presentation. There's increased likelihood of institutionalization because the families can no longer manage them at home. So it's things like lifting, it's things like being able to change them that determine that you may need to put them in an institution or find somebody to come in and care for them. There's increased health costs. Maybe because they're falling more, maybe because they're not taking their medication because they don't remember, right? Increased risk of death. So what causes this mobility, this loss of mobility? If you look in this slide, you'll see the difference between someone's normal brain and the brain of somebody who has Alzheimer's. And we call this neurodegenerative changes. So as I said, remember, this is not a perfect picture, so everybody's brain is not gonna look like this, but it just gives you an idea of what's going on. You may also have some cerebral vascular disease, some musculoskeletal or sensory changes, but all these are things that are going on a day-to-day basis, a slow progressive basis. So what can the physiotherapist do for these persons? What is our role? What are we coming in here to do? Are we coming in here to chat? Yes, we are. We're coming to talk about fall risk. We're coming to talk to the family. We're coming to talk to the patient. We're coming to see what's going on with you and how can we improve your daily living? How can we slow down this progression? Right? How can we maintain your independence? How can we maintain your mobility and strength and improve your balance? Because these are things that people are usually, who we see are coming to say to us, like, I'm having difficulty falling, I'm having difficulty getting up from chair. And we want to make sure that we make you more as independent as possible. There are a number of risk factors associated with falling, but we're going to go through them a little further as we go through. And there's some factors that are more modifiable risks. And these are things like what's going on in your environment. Are there things on the floor? What's going on with your medication? During a physical therapy initial assessment, one of the questions that we always ask is, tell me about your medications. Tell me what you're taking. Sometimes you'll realize during this time that they're taking medications that might make them sleepy in the morning. So usually what I will do is refer them back to their doctor so they can have a discussion with them about how they're taking the medicines, or talk to the pharmacist so they can, maybe change out how they're doing it. So the meds that make them tired, you take those at night, while the other ones you take in the morning. So you're not going through the day just feeling drowsy. Right? What's happening with your mobility? Is this getting up for the chair a recent thing? Or has this been going on for the last 10 years? Is it that you have a stiff hip? Is it that you have arthritis in the hip? What's happening with the activity level? Have you been getting up on a regular basis? Have you been exercising? Or have you been living a situation where you go to work and then you come home, watch TV and go to bed? What is your activity level like? What sort of weaknesses you're having, and where are you having them? What sort of gait deficits are we seeing? What are you shuffling? Is it that you're unable to clear your feet? What's happening with your balance? Are you good standing with both eyes open, but as soon as you have to close your eyes, you have difficulties? Are you good on one leg? Are you not so good on one leg? Are you having dizziness? Are you having syncope? Is there some sort of hypotension going on? And is that because of the medication, or is it something else? Is there a level of confusion? Is there a level of depression? And are these things related to medication, or do they need to be medicated? Are we having hearing problems? Are these problems something that are being addressed? And if they are being addressed, is the hearing aid that you're using working for you? It's amazing to me how many people have hearing aids, and the reason why they're not wearing them is because they're not comfortable with it. But instead of saying something and saying, well, when I have this in, I feel very confused, and maybe having the settings on the hearing aid changed so that, they're not feeling this issue, or discussing it with someone who knows a bit more about it so that we can get it fixed. Are they having urinary incontinence? So they're uncomfortable going out. They feel as though, I'm going to make a mess. There's so many other issues that can be modified, right? There's certain environmental risks. When you're looking at the houses that they're living in, is there a lot of clutter? Let's talk about the surfaces. Are the tiles fitting flush on the floor? Or is there that tile lip that's up a little bit that when they walk, every time they go to the bathroom, they trip a little bit on their way in, right? How is the lighting? Is there poor lighting in the environment? Is there too much light in the environment? So when you walk, the sunlight is hitting you straight in your eyes and you can't actually see where you're going. Do you have stair railings or grab bars? And these are things that we would have discussed during our fall assessment. So we would try and put them into place so that we know that when you're using your bathroom, when you're using your shower, you're using them as safely as possible. Are they loose rugs on the floor? We have this habit of putting these occasional rugs or these by the beds so that, you get out the cut bed and you're not putting your feet on the cold tile, a very Caribbean thing. But if that rug doesn't have an anti-skid backing, when they stand up on that rug and that rug slides from on them, is their balance good enough that they don't fall with these rugs? Or do we just need to remove the rugs? Is there drip? Whether it from a sink, or it could be from a sink, it could be from a water bottle that's dripping onto the floor. We need to remove it. Are there trip hazards in the place? It could be a small toy, it could be a cord. There's so many different things that you may see and not necessarily think are hazards that are there. Debra was mentioning about the curtains. There are curtains that blow, and they see them as you have issues, and they're thinking that there's something going on with the curtains. So they're very frightened of that area. Removing the curtains will make them feel more secure in their environment. All right. Okay, so let's talk about the personal fall risk. We spoke about these before, but let's go back a little bit more into it. So we're talking about things like reduced mobility, whether it's because the joints are stiff, whether it's because the joints are weak, whether it's because of lack of use. So there are many people whose reduced mobility and even ability to get up from falling, they don't know the last time they sat on the floor, so they don't remember how to get up from the floor. So we just need to remind them, this is what you do to do that, right? Do you have reduced proprioception? Is it poor balance? Are you having reduced vision? What's going on with you? And are these things that we can change? are these things that require a little bit more from a physiotherapist or somebody who can train you to help make these a little better, to help you with these tasks? Are you having difficulty understanding what we require of you to do? All right. So let's go through these and see how the physiotherapist can help and how we can make this a little better for you. Right. This is just a diagram that I found very intriguing. If you look at this and imagine all of these things in your day-to-day, in your space, how difficult it would be for you to manipulate this space. And most of us are not suffering from dementia. So imagine how it would be for someone who does have dementia and is having all the spatial issues, the cognitive issues. So let's work together to make things better for them and for us, the carers. Okay, let's talk reduced mobility. Big thing for us physiotherapists, because we do a lot of gait assessments. So when the first thing we do is, as we see a patient walking, we want to look at how they're walking. Are their steps equal? Are they leaning forward? Is their balance off? Are they walking slowly? Are they walking slowly and then walking very quickly? Can they manage to negotiate turns? Are they able to do steps? Can they manage to climb a ladder? Even though very often at this stage, you know, we try to tell people this is maybe not the right time for you to be climbing ladders, but you know, Christmas is coming and you know what happens then. How about obstacles? Do they see things in their path? Are they able to climb over an obstacle in their path? If a book falls while they're reading and they get up, will they see the book on the floor? Will they remember the book is on the floor? And then can they step over the book? How can they get up from standing? How easy it is for them to get up from lying? Right? That is a big point, right? If you're caught in the bed and can't get up, then how can you go to the bathroom? How can you do other things? So in comes a therapist and we start doing all sorts of fun things with mobility. I also believe, this is just my personal belief, that whatever we're doing with patients needs to be fun and exciting for them as well. Yes, it's going to be tedious. Yes, it's going to be hard. But if I have a patient who really hates doing obstacle courses, but enjoys doing salsa dancing, let's salsa dance. Let's just find a way to do it, to get the movement in, to get the whatever it is, the task that we're trying to get done. Do we need to do it to music? Okay, you love the salsa music, so we're going to do it to some salsa, we're going to do it to some calypso. So we're making it enjoyable. They're enjoying what they're doing, and then it means that they're more willing to do it. Do they like being outdoors? So can we move the obstacle course outdoors where they're happiest? Because when I'm making them do it inside, it's easy, or it's just, why am I doing this? Not, they don't want to participate, but I take it into their garden where they're happiest. And we've now added another level to it. We're walking on uneven surfaces, but they're enjoying this. This is where they want to be, all right? And they will participate more, all right? With our obstacle courses, we do them a number of different ways. We may do them and they progress with the patient. So we may start as simple as saying, okay, we're setting this up, but all we know we can do is just walk around these large blue boxes or whatever they are. As they get better and realize, okay, we're going to add in different surfaces so they can stand on the different areas, mattresses. We may ask them, when you go around the blue circles, press the white dot. Can you bend to press the white dot? There are lots of areas that we can add into it to make it more difficult, to make it simpler, whatever needs needed. And as I said from before, everything is done on an individualistic basis, right? We're doing things like the figure of 8 walking, just to make sure that you can do those corners. Unfortunately, there are lots of corners in our lives, and so we need to make sure that we're able to handle this. Initially, we may start with them being able to walk and, look at their feet as they're going, just to make sure that they're going the way that they want to do and they're as comfortable as possible. We can progress it to them, working at us because usually the therapist is walking either behind them or in front of them, depending on what sort of support they need. Then we can progress it as they get a lot better to them looking at a particular point while they're doing it. So we're adding in some other neurological work in there, just to make sure that we are progressing and we're giving them as much tools to help them stay as mobile as possible. All right. We're going to be doing things like helping them to get over obstacles, gait training, using different devices. We can use these hurdles to do not only stepping over, we can add in balance activities here to have them bend. All sorts of fun things can go into this. You can go over and catch balls. So we're incorporating not only being able to walk in a straight line, but if something comes and hits you over while you're walking, or, you know, so that we are making sure that you're as stable as possible for as long as possible. All right. There will come a time when you will may need a mobility aid, and the physiotherapist is the person who can not only guide you on what aid is best for you at the time, and maybe suggest as the disease progresses what you may need to progress to, but also adjust and train. It's one of my pet peeves when I see people coming in and there's a 6 foot tall gentleman and his walker is adjusted for my height. I'm 5 foot, and he's leaning over the walker. I'm just like barely making it into the room. And the first thing you do is adjust the walker so it's appropriate for their height. And all of a sudden they're walking at their full height and they're looking good again. And it really improves their confidence, right? So we're looking to keep you as mobile and as confident as possible. Okay. Now, let's talk about proprioception. Proprioception allows us to detect the position of the parts of our body as they relate to each other as we move through our environment. So this is not only knowing where our body is in terms of, is my hand by my side? Is my hand up? What am I doing with my hand? We're also talking about how much force is required to pick up a cup, how much force is required to press the remote on the button on the remote, how much force is required to do any activity, but also how much to be able to coordinate the movement. So if I want to use the remote, I need to be able to lift it up, point it at the TV, select the correct button, and then press it, right? If I have no body position awareness, while I'm moving the remote, I may have to move my whole body to kind of get it over there to kind of press it. And that's not what we want. We want you to be able to singularly use the joints and use them in tandem with each other to be able to do these movements in a nice flowing way, all right? Proprioception retraining, I actually go a bit further than what this diagram is talking about. I assess joint by joint because very often when you see people and you see them walking or you see them doing things, we may assume that it's their ankle that's causing the problem because it just looks like they're not lifting up, or their hip because it looks like they're not lifting up their foot high enough when they're walking. When you actually start doing the individual proprioceptive testing and then, you know, the drills you realize, no, it's not actually the ankle, it's not actually that hip, it's the ankle that's not moving as well as it should, or it's the balance on the other foot while they're there, they're just not feeling secure. So I start with all the joints and I'm looking for things like not only can you do the movement, so I want you to make a circle with your wrist. I want to make sure that you can do the full circle and it's actually a circle. I don't want you doing a D. I want to make sure that that movement is looking good. It's going in the direction that we want to do. And if I say to you, okay, we're changing direction, you don't have to stop and there's a jerk or whatever. Not. We want to make sure that movement is smooth as we change directions and during our movement. All right. We're going through joint by joint. And very often a lot of my patients go home with proprioceptive drills so that we are making sure that their brain understands exactly where their body parts are, exactly what they're doing. And so then we can make better informed decisions because our map is clear. All right. Okay. Now, from proprioception, let's head on to balance because proprioception and balance are so closely related. As you can imagine, if you don't know where your limbs are, then you don't know how to stand up on them. You don't know how to utilize them. You feel as though you're putting all this extra energy in to kind of get any sort of movement done. There are a lot of factors that contribute to good balance. And if you're having issues with vision, if you're having vestibular issues, if you're having any proprioceptive issues, any issues be with an inability to figure out what's going on or process the information about your environment, it increases your risk of falling. Right? So let's discuss this a little further. When you see the physiotherapist, the first thing they're going to do is they'll do a balance. They're going to do some balance testing. We want to see not only how you're balancing and standing, but we want to take it back a bit and check out your balance in sitting as well. I find it very interesting that when you put people in sitting and you ask them to close their eyes, you'll still see them moving from side to side, even though they're sitting. Very often people assume that this only occurs when people are standing, or when they're sitting and you ask them to lean to one side, they will fall. And if you're falling and sitting, what's going to happen when you're standing? Sometimes when we were training to balance, we have to go back to sitting balance before we can actually get you to standing balance, because you've lost so much of the sitting balance ability, or knowing where your body is when you're sitting. Right? Traditionally, we used to do a lot of balance retraining using different surfaces. So you had soft surfaces, you'd have outdoors, you do a lot of one-legged work or two-legged work. Right now, we tend to, from a neuro perspective, we're adding in a lot more vestibular rehabilitation. Your vestibular system lies within your ears, and this is responsible for letting you know where the horizon is. So if your vestibular system is off, you might believe that your world is tilting like this, even though you're standing upright. So if your body is telling you that your world is constantly like this, you will always feel offset and you won't really know how to walk in a straight line. If we can get it to a position where your body understands that this is straight, then we can get your balance back. We can help you get back to being able to do the things that you love to do, and your balance is back to where it needs to be. It is not an easy fix. It is not, we do one exercise and you're good to go. Vestibular retraining requires that you're doing the drills on a constant basis for a while. And as you get better, it's amazing what we can see with balance. It will require that if you're traveling, you have to stop and reset your vestibular system, because it's so affected by what's happening within our world and within our environment. But I'm here to tell you that once you start the training, you do see really great results. All right. Let's talk about vision. Dementia patients are known to have ocular motility dysfunction and poor visual attention. This picture here is a representation of how the visual fields look to persons who have had dementia, who are going through dementia. And can you imagine that this is your loved one who you've known for many, many, many years? You remember their face, and when you look at them, this is what you're seeing. It explains up to me quite often why they will not be able to recognize people, because I'm not sure I'd be able to look at that image and put it to, coordinate it with my loved one, right? So, and if you're having that difficulty just looking at your loved one, imagine what the rest of your environment looks like. To me, that would be very, very difficult and very scary. So we need to be aware of this, and we need to do some stuff to help them with their vision. We want to be able to help them to see things, to stabilize on objects. So we're doing a lot of visual gaze stabilization. So we're looking at things, we're picking out objects. We're doing gaze stabilization, and we're doing coordination charts. So I want you to be able to look at this chart, tell me what this chart is saying, and then do an action from this chart. So it may be, all right, every time you see something on the right, you're raising a right hand. Every time you see something on the left, you're raising a left hand. Anytime you see anything in the middle, both hands are being raised. So that we're getting them to do something with their vision. We're doing things like puzzles, where we're having them find, and we're not talking about those 5,000 piece puzzles. We're talking about a 30-piece puzzle, where they have to look for the pieces, they have to be able to put these pieces together. And it may be even something even smaller, like a 20-piece puzzle, depending on where they are at. We take the puzzle pieces, and they're required to fix the puzzle. We can do this in sitting. If we want to make it a little harder, we may do it in standing. So we're incorporating different parts of our our therapy together, we're stacking it. We may do things like use the apps on their phone. There are tons of free apps available to use with vision rehab. Lots of things that you can have them do while they're sitting down quietly at home, right? There are coloring apps. There's all sorts of apps available. It just requires that you spend a couple of seconds maybe looking through the apps and teaching them about the apps. And remember, they will forget. So even if they play it today, and then they come back to you tomorrow and say, how this goes again, just be patient. They're not remembering. But once you get them on the path to keep doing it again, they will pick it up and be able to use it. Very often they have difficulties with the task, to understanding the task required. This affects both them and the caregivers. It's very frustrating for the caregiver when you're accustomed to saying, Dad, meet you by the car. So all of a sudden having to say, okay, Dad, we're going to the doctor now. Come, let's put on your shoes. And you may have to help them put on their shoes because they're not remembering how to tie the laces. And then you're saying, okay, Dad, we're going to go to the car now. We have to go down these steps. So what used to be a one-word instruction now has to be broken down into 5 or 6 different steps. All right. It also requires that we have a level of patience. And sometimes it just may require too that we modify a lot of the things that they're doing. So instead of giving them shoes with laces, maybe we give them those push-on shoes like the new Skechers, no bend-down shoes. I really like those. Or we find ways of modifying the task so it's easier for them and for us.
Melissa,
right?
sorry,
Yes.
Melissa, can you hear? Sorry,
yes, I can hear you.
Just because Alexia was supposed to talk at 10:45.
Okay.
And we have Kartheka coming in from overseas as well at 11:50.
No problem.
But I do
I'll
want
wrap it up now.
But I would ask you if it's possible for you to remain so that Alexia and Kartheka can talk and then we take your Q&A. Is that possible for you?
Yeah, that's no problem.
Because it's a great talk. And I think there'll be a lot of questions, but we just have to defer it because of the timing for those 2 young ladies.
No problem. No problem at all.
Thank you.
Right? Okay. So
Thank
this
you.
stuff here, we will do more of this with along with the occupational therapist. And literally, in conclusion, we as physiotherapists will not only help you maintain mobility and balance, reduce the risk of falls, and help you with your proprioception and vision. We also are here for the family members to help you guide you through this process and to help you to cope with any questions that you may have for both the parent, the patient, and the family. All right. Remember, the dementia patient is not giving you a hard time. Their dementia patient is having and living a difficult time. Let's work together to make it better for them. Thank you. All right, Debra.
Thank you so much, Melissa. I'm sorry to interrupted you. I love that talk. I am a physiotherapist, and that was like a fan. So I loved your talk. I'm always so impressed with you. Whenever I interact with you, I'm always so impressed with just everything you do. The level of quality is always so wonderful. But you know this already. So because I say this to Melissa very regularly for those of you who are not privy to our private conversations. But you've covered so much ground there about polypharmacy risk. Thank you so much for the PAHO 2023 statistics. Because it's, as I said, we anecdotally feel like vascular is well, I know in Jamaica, the statistics I'm talking about are really from Jamaica particularly. But it is good to know because with all of the emphasis on Alzheimer's, it is kind of annoying sometimes. I say this in a sort of measured way because you think we have so many other very common forms, subtypes in the Caribbean that we do need to look at more closely. So thank you for the PAHO statistics for sure. And I also want to just say 2 more things and then I'm going to ask Alexia to talk, introduce Alexia and ask her to talk. One is for everyone listening, please, whenever you have mobility aids, they really should be seen, assessed, and adjusted by a physical therapist. Melissa made that point, and it is really true. You can cause yourself more injury with a poorly adjusted walking aid and endanger yourself a great deal more with a poorly adjusted walking aid. So I would really encourage you to really get those things assessed if you insist, because in Jamaica we sell them in the pharmacy there. So a lot of people just pick up a cane, just pick up a walker, and as you said, they come walking into you, and you're like, oh wow, this is problematic. So we do want you to seek our help for those simple things, or what appears to be simple things. And also the last point that she made, which I think, aside from that last slide, which says everything, they're not giving you a hard time. We do need to talk about the fact that balance can be retrained. I say this very often, and people seem to, because with age our balance does change, and we do need to know that some of that is regainable with exercise and with the intervention of a physical therapist. I want to invite Alexia to come into the room. Alexia Blair is a speech therapist. And for those of us who have questions for Melissa, hi Alexia, looking all pretty. For those of us who have questions for Melissa, I'm going to just defer Melissa's question and answer until Alexia has talked, and Kartheka. Kartheka comes in from the UK and she's up at 5 in the morning, so I don't want to hold her up too long. And Alexia is working, so I want her to come do her stuff and leave so that she can get on with her day, because I'm extremely grateful to her for even agreeing to come and give this talk, because she agreed, like Winsome, she just thought it was like, yeah, sure, I'll definitely do it. So let me introduce Alexia. Alexia is a speech and language pathologist, as I've said before. She works with both children and adults who have communication and swallowing impairments. I cannot say enough about the fact that we don't know enough about speech therapy. That's just me ad-libbing. So I'm really happy that Alexia is here, because they contribute so much. And I don't think, especially in the area of dementia, and I just don't think, and in any area, and I just don't think we know enough about them in the region. Alexia completed graduate studies at the University of North Carolina in Greensboro, and she did her undergraduate at Nazareth College in Rochester, New York. She has worked in several environments, in schools, skilled nursing facilities, hospitals, and is now the director of Hello Speech Therapy in Jamaica. So proud. I'm so happy to see this. She is, of course, a member of her professional associations, the American Speech and Hearing Association, and also the Jamaica Speech and Hearing Association. So welcome, Alexia. Thank you so much for taking the time. I'm going to mute my mic and my camera and let you share your presentation. I can't say I'm looking forward to it. I glimpsed Alexia's presentation last night. It's great. So let me let you get started, Alexia.
No pressure, Debbie. Good morning, everybody. I'm Alexia Blair, speech language pathologist. I am sharing my screen with you all so you can see my presentation. Okay. All right. So today I will be presenting on the role of the speech language pathologist in dementia care. An overview. First, I will speak about the stages of dementia and which treatment techniques we use for each stage. I will also speak about techniques for communicating with persons living with dementia, and I will touch on briefly dysphagia in dementia. So the stages of dementia. First, I want to touch on the concept of retrogenesis, which is essentially the loss of mental abilities in the opposite order of acquisition. So when a baby is born, they learn to walk, then they learn to speak, right? So with dementia, you'll find that they lose their ability to speak and then they lose their ability to walk. There are 7 major stages for retrogenesis, and I'm going to speak about the matching developmental stages as well. So the overarching concept, it's the first thing in, is the last thing to leave. Okay, so with stages of dementia, there are 7. You start off normal, that's stage 1. Stage 2, you have normal aging, and that's when you start hearing things like, oh, I had a senior moment. You see Kathy, you speak to Kathy every day, and for some strange reason today, Kathy's name is just not coming to you. And then 5 hours later, you're like, right, Kathy, that's her name. And then with stage 3, that's when you start having that mild cognitive impairment. Things start showing up, and persons start noticing something is different, okay? And then stage 4, moderate cognitive decline. Stage 3 and 4, they're still able to live at home, mostly independently, with some supervision. Once you get beyond that stage 4, towards the end of stage 4, moving into 5, 6, and 7, that's when you need 100% supervision, okay? So 5, 6, 7, you have increasing decline, and 7 is typically when our patients pass. Okay, so this looks at the stages with developmental ages. So stage 3, you'd see patients that are performing at like age 12 years, 12 plus, okay? Stage 4, you see patients at 8 to 12 years. So this goes back to the level of supervision. Where you might leave a 12-year-old at home, you definitely would not leave a 5 or 7-year-old at home, okay? So you can understand now why we can say they can live at home, but with some supervision, okay? Stage 5, you see 5 to 7 years old. Stage 6, 3 to 5-year-old, and stage 7, newborn to 3 years old. Okay? And this can kind of help conceptualize how we use the different treatment techniques as well. So now I'm going to go even deeper, look at the different stages, the symptoms you expect to see, and what treatment techniques we will use at those stages. So with stage 3, patient behaves around 12 years old, okay? You wouldn't give a 12-year-old a car to drive, so probably wouldn't have these patients driving. And as Dr. Walcott Pusey said in her presentation, at stage 3, you typically see where, I've forgotten the point. I had a senior moment. I'll come back to that when it comes back to me. So the repeating questions, right? So stage 3, you see them getting lost, right? So you wouldn't give them the keys to drive because there's that increased risk of getting lost, right? So you see repeating questions. You might see some declining in their performance at work. And this is typically when persons tend to retire quickly as a way to escape being noticed, okay? Because they're starting to see these difficulties that they themselves are having, and they're hoping other people aren't seeing it either. You're seeing concentration deficits as well, difficulty with attention, and because they're having these symptoms and they're kind of having a silent inward battle because they're seeing this, they're wondering if other people are noticing, they're concerned about their health, what is causing all of this, and it's sometimes being kept a secret because they don't want to worry about the family. You start seeing some anxiety and some agitation and maybe some anger presenting at this time. As treatment, we start to jump into compensatory strategies. So there's still viable residual cognitive abilities, so we want to maximize on that. Yes, they're having difficulties remembering things, but if they write things down, they can remember better, right? So shopping list, you write down your shopping list, you're still able to participate in the shopping experience when you go to the supermarket with the family, right? You start seeing increased use of the calendar. They're forgetting appointments. You use your calendar or your diary, you write things down, you're more likely to make your appointments on time. You want to do things like environmental modifications. So if this person is having difficulty concentrating in a noisy environment, you might turn the TV off. You might remove some things from some visuals off of the wall. So if there are too many pictures and they're getting distracted, they're staring at the picture, you just give them blank walls to help them kind of focus. At this time, you're very heavy on the family and the caregiver training. Help them to understand what this person is going through. And you're also preparing them for the coming stages. This is what stage 3 is like, but the next step is stage 4. Look out for these symptoms so we can see if we're progressing or if we're kind of stabilizing. Some dementias progress faster than others. With stage 4, they're at about age 8 to 12. They're having difficulty with orientation. There's difficulty managing finances. There's a need for increased supervision. At this point, the person is definitely becoming more aware, and those around them are also becoming more aware of those deficits, right? So you start seeing things like denial. This is where I get my patients who say, when you get to my age, you don't look at the calendar anymore. The days just run into each other, right? Or if you're giving them an assessment, nobody could get this right. This is a stupid assessment. There's denial. They're aware of these deficits, but they're like, this could never be my problem. It's something else. At this stage, we're still having some residual cognitive abilities, so we're maximizing on those. So we're teaching compensatory strategies. At stage 4, this is when we encourage our physical therapists to train or at least expose the patient to using those mobility aids, right? Because this is one of those last moments where there is some cognitive ability, where they're able to learn new information. Okay, beyond this stage, it's very difficult, almost impossible to learn new information. Actually, no, not impossible. I'll tell you a way how to do that later on. Okay, so we're encouraging our physios to teach how you turn with your walker, how you stand with your walker, reminding you to lock your brakes before you stand up. Okay. In terms of memory recall, we want to log activities that happen during the day. So you're having them, oh, what did you do today? First, I went to the supermarket. Then I went to the store, right? You want them to pull on what they've done during the day because we're exercising the brain that way. We're teaching sequencing tasks with visual aids. So for example, this person loves peanut butter and jelly sandwiches. We're showing them pictures of how to make that peanut butter and jelly sandwich. We're showing them pictures of how to make of a recipe so they can do it themselves, right? And again, we're using these visual aids because as the disease progresses, then they're going to be using these visual aids, but we're going to simplify them with time to make it easier because as it progresses, complex is more difficult because it's complex. We also want to engage our patient in meaningful tasks. I can't stress enough, I will say this multiple times, engage the patient in meaningful tasks across the stages because they are aware that things are changing for them, but they still want to feel useful. They still want to feel included, right? They still want to know that they're able to do things. So what we do is we interview. You find out what they used to do at work, what their hobbies were, so that you can create an increased feeling of work. So if this person used to be a teacher, you might give them papers to mark, right? You can pre-fill some sheets, put some right, put some wrong. You can give them an answer sheet and have them mark some papers, okay? That helps work on their attention. It gives them something to do. They'll love knowing that they're helping you, even if this is just something you did for them. They think they're helping you. They've gotten a feeling of worth. They have a purpose. And again, you're doing family and caregiver education so that they can, it's pointless if this patient comes to the therapy room and I give them things to do. When they go home, they're just sitting in front of the TV. So you're giving family and caregiver education so that the family can incorporate these techniques at home with the patient so that they're always stimulated, okay? And then we move to stage 5. This is when we start see our 5 to 7 year old presentation. And with a typical 5 to 7 year old, they're going to wear their favorite shoes every day because these are my favorite shoes. They could be dirty, they could be smelly. No, you can't take my shoes. They're my favorite shoes. You can't wash my favorite shoes. You'll see the same thing with our patients. They typically, or they like to wear the same clothes daily, right? There's inconsistent recall of major events. So they might remember, yeah, I got married, but they can't remember where or when. There's difficulty managing medication. And again, if you think about a 5-year-old, you give a 5-year-old the medication. No, I don't want to take that. It tastes yucky, right? You start seeing behavioral problems and depression. And this is why keeping our patients engaged is so important because the devil finds work but idle hands, right? Nothing could be more true. This is when you start seeing our patients wandering into rooms and playing with another patient's favorite brush, right? Because I don't have anything to do. I'm going to go where I want to go and I'm going to do what I want to do with no regard for anybody else, okay? So our treatment. At this point, compensatory strategies are no longer applicable. Again, because we're not able to learn new information quite as easily. So what we do, we can work on memory books. So you create a book with pictures And you might, with the progression of the disease, you might have to simplify the labels that you use. So you might move from or wedding day, right? Or instead of saying, or wedding day, you can say marriage, or you could say wife, right? So you're using less words as it progresses. At this point, you want to keep your questions simple. So you're using yes or no questions, or you're using multiple choice. You're shying away from doing open answered questions, because it's easier for somebody to answer, what do you want for lunch? A hot dog or a hamburger, versus what do you want for lunch? Because now you have to tap into word retrieval. You have to open the category with food items. You need to sift through all the food items and pick the food that you want to eat. Remember the food you like to eat, right? And remember the foods that are available. So you make it simple. Do you want a hamburger, yes or no? Or would you like a hamburger or a hot dog? Okay. At this stage, we also encourage to have longer meal times. One factor that leads to increased risk of aspiration is if the patient is not able to feed themselves. Whoops, sorry, I am going in the wrong direction. Okay, right. So if the patient is not able to feed themselves. Is there a question for me? I'm hearing something, or is somebody unmuted? Keep going. Okay, keep going. Right, so what we see is that patients get assigned a feeder because they're sitting at the table and they're taking too long to eat. And then the feeder is just shoveling food for a patient. Patient doesn't have a time to catch a breath, a time to swallow properly, then they start to aspirate, right? They're also losing that sense of independence. They're fully capable of feeding themselves, right? So the suggestion is to give them a longer meal time. They can sit there for as long as they want. They might have somebody supervising them who might cue them. Oh, take another bite. Did you forget you're having lunch? Or, oh, that food looks good. You should take another bite, right? Give them that cue to remind them to eat. They're more independent and they're eating. Yes, it might take them twice as long, but they're still getting the job done, okay? And again, meaningful activities to decrease isolation, right? You don't want this patient shrinking into themselves. You want to keep them involved and engaged so that they're doing things and they're stimulating their minds. Stage 6 ranges from ages 2 to 7 years old. And at this point, you start seeing difficulties getting dressed, difficulty showering, you start seeing incontinence. They're misidentifying familiar people. So the wife becomes the mother becomes the aunt. They're not recognizing the faces quite as well. Speech does not make sense. They'll be having a whole conversation, telling you all kinds of things, this whole story, and you're just smiling and nodding because you have no idea what they're saying, but they're engaged. So you just smile and nod and you repeat and you go, so they know that you're listening to them because that's that social connection, okay? At this stage, you also start seeing things like hypersensitivity. So they're not tolerating wearing their glasses. The dentures are suddenly uncomfortable. There are suddenly spiders crawling all over them, okay? They're having more fidgeting and they're pacing. There's this fear of being alone and you see outbursts or violent behavior, okay? The treatment is, again, structured activities that lean towards their interests. And I'll talk some more about those structured activities. 3 techniques that I really want to emphasize is validation, reflective listening, and redirection. And I will give you examples and ways to do that further on in the talk, but just like keep that in your mind: validation, reflective listening, and redirection. And this is what I was talking about with simplifying memory aids. So again, memory book, before it used to say, or beautiful wedding day, and now it says wife, okay? So you're moving from those long sentences to short words, and they get the job done just fine, okay? And again, can't emphasize enough the family and caregiver training, because it is going to hurt when someone you love no longer recognizes you, okay? So just remind them, this is not because they no longer love you, it is the nature of the disease, okay? And that can help comfort the family members. And it can also reduce agitation for a patient, because sometimes family members are like, no, I'm not your mother, I hate your mother, right? I'm your wife, don't you remember me, I'm your wife? And it becomes argumentative, combative, and that makes our patients more agitated. So the the family knows beforehand what to expect. Then when it happens, you can sort of reduce that agitation. And stage 7, again, I said this is usually when our patients pass. And what we do in this stage is we do damage control. We're minimizing the risk factors, right? At this stage, you see reduced verbal output. So our patients aren't speaking nearly as much. You might get 1 word for 12 days, if you get a word at all. They're at high risk for aspiration because they're bedbound. Their inability to hold up their head, so their head is down and they're eating, right? They're probably not swallowing properly. They're likely to aspirate, okay? You see grimacing facial movements, and you rarely see a smile. And this is a stage where people say, well, he has dementia, I can't really do anything for him. No, and it's the complete opposite. Because remember, this stage is newborn to age 3, right? And what do we do with newborns in case age 3? We keep them stimulated. The baby wants to be held, right? The 1-year-old, the terrible twos, you're busybody, you're all over the place, right? You need that stimulation. This is the point where you need stimulation the most, right? You want to keep that person engaged. It might look different from the other stages, but you have to keep them engaged. And for that, you kind of lean into your sensory stimulation. So you think about your senses. With sense of smell, you might use some essential oils. You have your lavender, eucalyptus oil. You can use familiar food smells. I love curry. I think I would love to smell some curry, right? So you look into things that the patient likes and provide that stimulation. You give them visuals, show them pictures of family members, pictures of pretty things, pretty animals. I love elephants. I would love to see an elephant, right? You think about tactile, so massages, the deep pressure massage, nice and soothing, versus the feathery touch, which kind of feels like bugs crawling all over you, right? So you kind of think about that as well. Hearing, you play their favorite song, play music from their era, the music therapy. I think every one of us so far has spoken about music therapy. Cannot emphasize that enough. At stage 7, you want to maintain hydration by whatever means necessary, and avoid aspiration because again, high risk for aspiration pneumonia. Maximize nutrition as well. All right, speech therapy techniques. So a big one that kind of, they go together. There's errorless learning and there's spaced retrieval. Errorless learning is exactly that. No mistakes are allowed. So if you have to, you give the patient the correct answer. So you ask them a question, you wait for a little bit, and then if they don't give an answer, you give them the correct answer. If you think they're going to respond incorrectly, you give them the correct answer. If you can't catch them in time, you don't give a negative response. You don't say, no, you're wrong. You just give them the correct answer, and then you move on, okay? So that's errorless learning, and you use errorless learning when you're doing spaced retrieval. So the premise for spaced retrieval is, or the idea of the instructions for spaced retrieval is that you ask the same question repeatedly. You ask the question, the patient recites the same answer. You incorporate some tactile cues, right? And then it helps to cement it. So giving you the example, let's say you want a patient to increase their water intake. So you'd ask them, what do I do when I see a glass of water? That's your question. And then the answer would be, I drink it, right? And you ask the question over and over, what do you do when you see a glass of water? I drink it. What do you see when you see a glass of water? I drink it. What do you do when you see a glass of water? I drink it. When the patient demonstrates that they have fully grasped the answer to the question, you give them some space, some time. So let's say it's 5 seconds. So you go, what do you see when you see a glass of water? I drink it. Then you wait. 1, 2, 3, 4, 5. What do you do when you see a glass of water? I drink it. Once they've demonstrated that they've gotten it, you increase the time to 5 seconds, 10 seconds, 20 seconds, 40 seconds, right? And you increase. When you get to a minute, you start going up by 30-second intervals, and then you gradually increase. If the patient gets it incorrect, then let's say they get it incorrect at the 20-second interval, then you go back to 10, okay? And you ask them the question at 10, then you bump it up to 20 to see if they've gotten it, okay? That's the way it's designed, but I've also heard of therapists who go right back to the beginning and retrain it. I mean, you can't practice it too much. And the idea behind spaced retrieval is that you're trying to make the activity or the action a procedural memory. So you want to make it like riding a bike, something that you won't ever forget. You do it often enough, it comes to you, okay? You can use spaced retrieval across the stages. With stages 3 and 4, the intervals can be longer, whereas because they're still able to retain new information. But with the later stages, the interval is shorter because you have to put in more work to get it to stick better. Another technique is ability-based intervention. And this is where I go to with the structured stimulating activities, right? So you want to relate it to what that patient's former job was, what their hobby was, or what their interest was. So if you have a patient who used to be a teacher, like I said, give them papers to mark. If you have a patient who was a housewife, you can have them sort the laundry, or have them sort the silverware, have them set the table, right? So you go into their interests. The patient loves to garden, have them plant some seeds. And for this, you are not focusing on the accuracy. They can do it incorrectly, they can do it partially. What you're focusing on is the act of doing. They're doing something, right? You want to keep them occupied because boredom leads to agitation, right? And another technique is reminiscence therapy. And this is where the patient reflects on past life experiences. It can be done one-on-one or in a group setting. Group setting leads to better results because it's social, you're interacting with other people, you're hearing other stories, right? And you're making connections. With this, the lead would provide a prompt or a theme. You can talk about Christmas, you can talk about Sunday dinner, you can talk about vacations. You pick a theme and you discuss it. You try to incorporate pictures, you're appealing to the senses, music, smell, taste, touch. You want to use yes or no or choice questions, like I explained before, it's easier to follow through. If you do use those open-ended questions, lean more into episodic memory. So what happened? So let's say, your wedding day. What happened on your wedding day? How did you feel on your wedding day? Versus, when did you get married? Which looks more at your semantic memory, and that's very fact-based or fact-driven. And now we're going to talk about some techniques for communicating with persons living with dementia. First up is reflective listening, and that is listening to the patient with empathy and offering understanding. Wow, I promise I know how to spell. That's understanding. So what you want to avoid is judging or problem solving or discounting their feelings. So for example, a patient might say, I cannot stand that nurse because she always comes in here and she always just throws water all over me and now I'm all wet, right? So what you don't want to do is say, you know that nurse never threw water on you. Or you don't want to say, let's go get you changed. Yeah, there's water all over you. That's problem solving and the person who's judging. So instead, with reflective listening, you would say, it sounds like you're feeling angry and maybe even a little uncomfortable because your clothes are all wet, okay? So we said, sounds like you're feeling, we've identified the feeling, and we've identified the reason, right? If you don't know the reason why they're upset, you can label the emotion. So if the patient is just walking up and down the room cussing, you can say, oh, it sounds like you're angry. Then you might ask some probing questions and you might come to the reason that they're angry, right? But it's important to take time to listen. Another way to communicate is with validation. So you want to wow, I am losing points for spelling today. Good Lord. You want to validate or accept what the patient says regardless of accuracy. So again, with our patients with dementia, you might see things, they might be living in the past, the present, or the future in a given moment, or they might be hallucinating. So sometimes you might hear some outlandish things, right? It is not our job to force our patient to join the real world or to bring them into our world. We want to understand their feelings and their behaviors. We want to listen to their hallucinations, or if they're blaming someone for something, we want to validate them, okay? So for example, we might have a patient who says, I don't eat food from the dining hall because they always have worms in my plate. You might say, there are worms in your plate? And they'll show you the worms in your plate and you go, oh my goodness, let's go get you something else, right? You're not going to look and say, hey, see, there's no worms, because they could be hallucinating and you can't tell them what they're seeing, because right now they're seeing worms. How do you explain that there are no worms if I'm seeing worms right now? Okay, so you want to validate it, even if it sounds outlandish, it's fine. They just need to know that you're hearing and you're understanding. Because if you argue with them, again, you might lead to some more agitation and you've had a whole escalated situation instead of de-escalating the situation, okay? And validation pairs nicely with the next point, which is redirection. And redirection is helping the patient to change the direction of their thoughts. So when you're doing redirection, you want to be calm and confident. You want to ask questions to figure out what is happening. So you want to get more information. You're using that reflective listening. So you're labeling the emotions and you're trying to understand what is happening. And then you can try introducing alternative activities or even saying something completely unrelated to redirect them. And a good example is you have a patient who says, I am late for the bus, I need to go to the bank, right? It could be 4 o'clock and you know the bank closes at 2, but he's late for the bus because he needs to go to the bank. It's now 1 o'clock and he can catch the bank if he goes right now, okay? So the patient is on his way out, we have to catch him, we have to redirect him. So we can say something like, oh, you know what, you might miss the bus. Help me find my keys and I'll give you a ride, okay? So now he might help you find your keys. So you redirected him, okay? While he's helping you find your keys, you can start some conversation like, oh, which bank do you bank with? Oh, you bank with NCB. Is it the NCB in New Kingston? Yeah, it's the NCB in New Kingston. How did you know? Oh, I love that NCB. Right beside that NCB is a juicy patties, and I love patties. Oh, I love patties too. And suddenly you're talking about patties and he's forgotten that he needs to go to the bank, okay? And I'm not saying that this works instantly, immediately, every time with every patient. You might have some combative patients who might say, no, I don't want your keys. I want to take the bus, right? And you might have to try again. Oh, all right, fine. We can take the bus, but you have to wear your shoes. The bus is not going to allow you on if you're not wearing your shoes. And you help them find their shoes, right? So you have to be quick on your feet. You have to be calm and confident. You can't whiffle waffle. You can't be saying, no, you can't go to the bank is closed, because no, it's 1 o'clock, the bank is not closed. He'll have an answer for everything. You don't try to judge, you don't problem solve, you get into his world, you match him in his world, and then you try to redirect him somewhere else, okay? Depending on what the scenario is, you can say something completely unrelated. So he might be saying, oh my goodness, I need to go see my daughter today. It might work if you say, oh my goodness, let's get some ice cream while we wait, right? He comes to get the ice cream, he's forgotten that he's waiting for his daughter. Okay, and now for some tidbits on dysphagia and dementia. Dysphagia is any difficulty that someone has with swallowing, okay? And our patients with dementia are at increased risk for that. So we're gonna speak about, very briefly, some things that we can do to mitigate that. I've divided it into 2 sections with an intact swallowing mechanism. So this is a patient who eats just fine, and you might find this with your earlier stages. And I've also separated it with impaired swallowing mechanism. You might see that with your later and final stages. So with the intact swallow mechanism, we can use spaced retrieval to increase hydration. And I gave that example with the what do I do when I see a glass of water? I drink it, right? And then you can incorporate glasses of water the patient comes to drink. With a grazing program, this is for patients who you can't quite get them to sit still for a full meal. You might see them picking on something. What you could do is reduce the quantity of the meal, but increase the frequency. So you have a grazing program. They might have an apple for breakfast, and somebody walks up to them at maybe 2 hours later and hands them a granola bar for them to munch on, right? So it's frequent meals throughout the day, and that can help increase their caloric intake. You have some patients who, even if they're sitting down, they're rocking and they're fidgeting too much, and they can't really pay attention to the meal too long to finish a complete meal. You can try things like sensory modulation for those patients, where you might give them a weighted blanket or a weighted stuffed animal to hold on to, that can help calm them down enough for them to complete their meal. With older populations, their sense of taste changes. They actually lose a lot of their flavors, but what remains the longest is their sense of their taste for sweet. And that's a lot of older folks have sweet tooth. So what you can do is, and when I was doing my graduate studies, my supervisor did this, and I gave her like a weird look because she put sugar in my patient's eggs. And as far as I'm concerned, that can't taste good. But he went from picking at it to eating the full thing. And I was like, okay, strange. But she explained it to me. They can taste sweet, they love sweet, they're more likely to eat more, okay? With a patient who has an impaired swallowing mechanism, you can do things like diet modification. So I want you to think about the patient who might be hypersensitive. He stopped wearing his dentures, so now he can't eat the boiled dumpling that he has on his plate. You can change the diet. You could do like a chopped diet where you cut things up for them. You could do like a mechanically soft diet. So instead of eating the dumpling, he can have a boiled banana. He might have some Irish potatoes. The food still looks like the food he's used to, but it's soft and easier for him to manipulate. And there's some patients who it's easier for them to swallow as well if they're having a weakness with their swallow. And it could be a case where you downgrade them all the way to like a pureed diet, okay? But what you tend to see sometimes with patients with dementia is if the food doesn't look like the food they're used to eating, they're not going to eat it. And you know what puree looks like. It sits in the plate and it's moving. And it does not look like food. I want my food to look like food. So what you can do is texture modification, where they have food-shaped molds, where you can put the puree in, and then when you remove it, it's shaped like food. And I have some pictures in the next slide so I can show you. My big takeaway with dysphagia is I want everyone to understand that a PEG tube is not a cure-all. What you tend to see is, oh, he has dementia, he's aspiration pneumonia risk, he's aspirating on his food all the time, let's give him a PEG. If he's not eating, then he won't aspirate. But even with a PEG, you can aspirate on gastric fluid. So with reflux, that's a high risk of aspiration pneumonia, okay? So then you get to a place where you have to decide, or you can speak with the family and help and guide their decision making, whether or not they want this patient to have comfort feeding, okay? This patient, end of life, should we avoid risk, or do we want them to be comfortable? I love to eat. I want food for as long as I can have food for. If we have to choose, give me the food, okay? They know their family member better than anyone else. Daddy would want to have the food, okay? At whatever risk, let him eat his food. That's when he's happiest, okay? Explain, document, and then you give the go-ahead for them to have comfort feeding, even if that puts them at risk for aspiration pneumonia. Okay, I'm going to show the texture modification molds. So as you can see on this plate, it looks like sausage, there's mashed potatoes, there are green peas, and I think those are either carrots or pumpkin, but that's pureed consistency, right? But it's been placed in the mold, which you can see on the right. It looks like the sausage or sausage mold. Put in the mold so it's shaped like recognizable food, but once you put that fork in it, you can see more clearly that it's pureed. It doesn't require quite as much chewing, it's easier to swallow, okay? And with that, I think it's time for me to take questions.
Thank you, Alexa. I was just about to say the same thing. There are two, I'm very grateful for that talk. I think it was extremely thorough. And I know I've certainly in my support groups, I get asked a lot of the questions that you've answered, and I've answered them in the group as well. You have answered them beautifully for everyone who is watching and who desperately needs that sort of solution. So thank you so much for it. That's why I was really, really excited about your talk, is because I myself have, you know, like I have a lot of experience with that, and your talk was wonderful. It's really covered a lot of ground that is functional, practical, and really, really gonna help a lot of people. I've spoken a lot about the molds because there is a tremendous amount of patients who are really, really struggling with the, you know, pureed food, as you said, unattractive, not recognizable. So lots of issues around eating and so on. And the moles are one of the things that can be really, really helpful. I am going to, there are 2 questions that came in the chat that I said I would just answer them live because it saves time. Someone had asked for the contact for my organization. I usually just tell everybody, just WhatsApp me. It's 768298200. If you WhatsApp me, 876-829-8200, I'll sort you out from there. It's just easier than me giving you like an email and then missing it a day or something. If you WhatsApp me, come straight to my phone. And WhatsApp me, let me know what it is that you need or you have a question about or whatever. And then I can either refer you on or help sort you out from there. I'm conscious that right now it's not, I'm really the only person basically. So it's just easier for me if you just WhatsApp me. And then whatever you need, because not all of your needs are going to be for me specifically, then I'll sort you out and send you on if you want to go, if you have other, if you have other needs. Another person has asked, if a person living with dementia repeats the same story many times, do you tell them that you have told the story before? No, you do not do that. We can talk a little bit about, Alexia has done a really great job on communication. Part of communication is body language, and people living with dementia are really, really great at seeing your facial expression and seeing your body language and picking up on it. So please also try, when the person is repeating the story, to maintain, as Alexia has said, a very calm demeanor. Try to remain relaxed in your body language. Try not to have a facial expression of boredom or annoyance. Don't roll your eyes, anything like that. See if there's no need to remind them that they're telling the story. Try to, there are 2 things I offer all the time. One is try to develop a tolerance for repetition, meaning, expect them to repeat stuff. That's part of what's going on with their brain changes. Work with it, as opposed to trying to correct it. Correcting it isn't going to get you or the person anywhere, and it's going to give both of you a lot of unpleasant memories. The second thing I would recommend also is if you can find, I use a whiteboard with some of my clients where you can put a whiteboard up and you can write answers put it up in a place that the person with dementia can see it easily, wherever they are most frequently. And you can write the answers to the frequently asked questions there, and you can, put it where they can plainly see it. That might cut down in some patients on the frequency because they're able to see the answer to the question they keep asking. Sorry, Alexia, because I wanted to answer those 2 live so everyone within earshot can save themselves some work on that. But if anyone has, Kartheka is up early in the UK. So Kartheka, I'm coming to you. I'm so sorry to have you waiting so much, but we're running just a little bit behind. If anyone else has any questions for Alexia, I think I see there's another one in the chat. Ramon asked me, what is your view with regard to allowing patients independence as long as possible? I'll answer and then Alexia can jump in as well, or any other one of the panelists. I believe that you should give them as much independence as you can as long as possible. Alexia, not just me either, the evidence is for that. Alexia has touched really nicely on what we call risk assessment and management when she's talking about the dysphasias and the swallowing risk, and saying, you have to weigh up at some points with these people. Do I want to feed them and perhaps they aspirate a bit, but they have well-being and they're enjoying their food? Do I need to install a feeding tube? How do I do that? With aspiration, as a physio, military will tell you the same thing. All of us as physios are thinking the same thing. With aspiration comes pneumonia, right? And that, of course, does lead to demise in a lot of our dementia patients. But again, even with that, and this might sound very shocking to say, even if with that, we can manage a pneumonia, but we also have to think about the quality of life. So risk assessment is a very, very big part, if you ask me, of dementia care. I do it almost every week with my patients. We talk about what is possible. We cannot and should not bubble wrap these people and let them sit in a chair. It has a very, very detrimental effect on their cognition. So they'll deteriorate faster, in other words. If we are fighting for the preservation of their quality of life and we want to delay their cognitive decline, we have to be willing to think through the risk of certain things. I tell the story all the time of a British patient I had when I was doing my master's. We put a GPS on him and he was able to cycle for 2 more years. He was able to cycle for, I think it's another year before they actually had to stop him. But because he, a policeman brought him home. But as Melissa mentioned as well, think through, and Alexa did a good job of that, to think through strategies when you're coming to manage a person living with dementia. It's about strategy. How can you compensate and how can you play to their strength, as opposed to saying, well, you can't do anything anymore, sit over there. The more that we preserve is the better they'll do. But think of the risk as well. You don't want to endanger people unnecessarily either, right? And there are cases of things like, there's strategies for wandering. I have a whole video on wandering on my page and so on. But I think you want to always think of assessment of risk when you're doing things. If there's some risk, but they can, it really promotes their well-being and they can do it relatively safely, I would tell you go for it. Because you can always work out a strategy as opposed to, basically imprisoning, someone simply because they have a condition. They will, there'll come a time when you won't be able to do that. You have to be able to reassess risk, but you should bear that in mind. Any more questions, Alex? Alex, if you want to jump in on that risk question, feel free. In terms of allowing people independence as long as possible, or anyone else as well. And then we're going to move to Kartheka because, she's up early. Go ahead, Alexia.
I wanted to go back to the question about the asking questions. So it might be helpful to think of the repeated questions as a symptom of the disease. So you wouldn't tell someone who has a cough to stop coughing, right? Or you cough tolerate, right? Excellent. But with that, you can employ you can answer the question and then you can redirect. So if he's asking, he said, that one time when I climbed a tree and I fell out of the tree, you can say, oh, I love that story. Oh, which tree was it again? And you can tell you about the tree, like, oh, I love mangoes. Let's go eat a mango, right? We're off that. He's asking questions or he's telling the same story because he wants to share information. He wants to be social, okay? Yes. So you match that need. Yeah, yes. That's it.
Excellent, Alexa. And for those who, Alexa has very smartly said, because some people living with dementia find redirection annoying, and they will be like, don't do it, they can get very sensitive. If you can't redirect them, I always tell everybody, lean into it. Say, just as Alexa has given you the cue, say, you seem very concerned about this. If they're asking about something all the time or mentioning something all the time, it's useful to remember that the way they communicate has changed. So sometimes if you lean into it and you say, you seem really concerned about this, and you ask them some questions and you let them talk, you might find that there's another concern, but because they don't have the verbal range they had before, they're not able to tell you, oh, I'm really worried about my dog or something else. They will ask you a question and ask that question over and over because that's what they have access to verbally in terms of expressing a concern. So sometimes if you have the time to, ask them a couple of leading questions so that they will talk it out, you can sometimes figure out what's at the bottom of that. My experience is actually dementia patients are, quite, they're actually quite sharp in some ways. It's just that the communication is off, that you get that verbal salad, and the way that they're saying things isn't what we would interpret, easily. But you can, they are always communicating. It's my experience. Let me just check one more time, Alex, if there's anything else for you. If you guys have additional questions, please feel free to leave them, even if Alexa exits, because I've mentioned we're all working therapists and all working practitioners. Even if Alexa leaves, I can convey them to her and we'll see if we can get them answered for you after the event, if not immediately. So going once, going twice for Alexa's questions. Any more questions for her? And then we're on to Kartheka. I'm just waiting another second or two, and then we're on to Kartheka, who is patiently, very, very gracious and patiently waiting. I have to tell everybody in earshot how much I love Kartheka. I met Kartheka once face to face. We had a face to face meeting, and her energy is so straightforward and wonderful. She's such an authentic person that I'm super thrilled that Kartheka can be here to talk about what she's created. So it is. I'm so pleased to have Kartheka here. I can't explain to you, just as I'm pleased to have everyone. But Kartheka has a special place in my heart. I had told everybody that I'm building a tribe, and Kartheka is tribe for sure. The way that she speaks, the way that she approaches things and everything is, I have a lot of love for Kartheka.
Well, thanks,
She's definitely
Debra, for that
one of
intro.
us. She's one of us. So don't wait. Interesting. Let me just briefly, because Kartheka has a very impressive intro. So I'm not gonna do all of it. You guys should know who she is, though, and please look her up. She's the CEO of Brainberry. So look up Brainberry as well, because you do need to. Don't miss out on Kartheka and the innovations that she's doing. That's what I would tell you. And I'm going to introduce her properly now, but it's just that I really love Kartheka. She's a great girl. So Kartheka is Bogan or Bohan?
Bojan.
Right. So Kartheka Bogan she heads Brainberry, which is a UK technology innovator. It's developed a home-based AI-driven Cosmo neurofeedback system. That sounds like a lot of big words, but essentially what I was talking about in the beginning when I was talking about cognitive stimulating therapy and how it's research-based, and how we pull from reminiscence therapy and everything else, Kartheka has put that into a program that also has a headset that reads the patient's reactions and tailors it. So it's such an amazing idea. Okay. So I'm sorry, I've already explained that. And Kartheka, she holds an MSc in biomedical engineering, and she has over 10 years experience in the field of medical devices. She holds 2 patents pending, one for Alzheimer's technology, and she has received several awards. If I go into it, we'll never leave here. Okay. So Brainberry comes out of Kartheka's personal experience of accompanying her own grandmother who had Alzheimer's on her journey as well. So Kartheka took her experience with a person living in dementia and has turned it into a creation. So please welcome Kartheka Bogan and Bojan, and I'll mute my mic now and let Kartheka speak. I'm so excited to have you here. Go ahead, Kartheka, it's all yours.
That was yeah, thanks for the intro. That's good. Hi all, I'm Kartheka. I'm CEO of Brainberry. I think you can see my screen, yeah. So yeah, I started Brainberry in 2015 with basically I had experience with Alzheimer's with my grandmother, and I was a teenager then. But because she started forgetting us, I kind of withdrew from her because we didn't get a diagnosis that time. We didn't know what it was. It took us from 5 to 6 years before we diagnosed she was a dementia patient. And by the time I completely withdrew from her because she couldn't recognize any of us. So when I finished my engineering, I wanted to start a business. I was looking for ideas. Then I just looked into my diary, which I wrote 10 years ago, and I wrote to myself, I'll do something for Alzheimer's one day. And that's when this company started. So that's the story behind Brainberry. Because my grandmother had a very slow progression of the disease, I was able to see each and every stages of it. So we thought we could develop something with digital therapeutics without the need for drugs at the very initial stages so that we can delay the progression of the disease for few years. So I'm not going to go deep into what dementia and their problems are, but we know there is no treatment till date or cure. And there's so much money and energy put on developing drugs. But personally, I think equal importance should be given to non-pharmacological and digital therapeutics, very at the early stages, which will help to delay the progression of the disease. So what we've developed is a digital gaming platform, and it's quite different from other gamification elements because it has two important aspects to it. One is it's very personalized. The second is we are measuring parameters that can help a GP, carer, or the patient themselves to understand where the progression of the disease is, and is this digital therapy really treating them or helping them, and where their focus of improvement should be. Because as you know, all dementia patients are different. Not everybody are going to have a reminiscence problem. Some might simply start with anxiety and stress, or for someone else, it could be just forgetting vocabularies. So it's very important to target those initial symptoms that each patient exhibit. So we got two things with this app. One is it's personalized, partially personalized, and the second thing is we kind of measure certain elements which really helps to understand the progression of the disease. Before I go into clinical validations, I would like to show the demo of the app. So there is two aspects to this gamification. One, we have a web portal, and the reason it's web-based is there is a session called Game Upload. So we ask family members to upload pictures of that specific user. So we got a list of things like families. We want them to upload pictures of a family, name of the person and their relationship. Then it's event. So we ask them to upload like marriage dates, birthdays, graduation, anything that's related to the person. Items is basically we ask them to upload items that they use regularly. This is dummy pictures, but items they use regularly, like the cup they use, or the chair they use, the diary, the book they read. So to identify colors. And we have schedule where we kind of ask the carers to write the list of schedules that the person behaves every day. And
Sorry,
songs.
Kartheka. On
Yeah.
my screen, I'm just seeing Cosmos clinical validations. I'm not seeing
Oh,
the
I
demo.
see. Oh,
Sorry
sorry.
about that. I should have probably interrupted earlier, but it's I'm not seeing the demo, so
Okay.
maybe
Can you see it now?
I'm seeing song list of yes. This
Okay.
is the demo.
Okay.
Thanks.
Okay. So, okay, I'll just do it from again. So there's two things to the app. One is a web portal. So you log into the web portal, and this can be accessed by the family members of the user quite remotely. So there is a game upload session where you have a family section. We ask them to upload a picture of the family member's name and their relationships. And next is event, where we ask you to upload pictures of their birthdays, graduation, and stuff. Item includes the daily items they use, like a cup of cups, chair, books, etc. Schedule is what their daily schedule. And songs, their favorite songs, list of songs. Right. So then comes the app. So once you upload it, the app opens, and there is 4 sections to the app. One is cognitive, physical, emotional, and behavioral. In cognition, we look at 7 elements. One is reminiscence, visual tools, decision making, daily tasks, spatial time, and language. So these are designed aiming at the initial common symptoms of dementia. So in reminiscence, I'm not going to go through all the games, but I'll show you demo of one game in each session. So we have a family tree. So basically, it's like the information you've put in the web portal becomes the question. So the user has to answer these things. The aim of these exercises, as their old memory is depleting or will deplete in the future, what we are trying to create is train them again and again with their family members' names and the events. So we're trying to create a new memory in the different part functions of the brain, and this is called neuroplasticity. I bet like everybody know what neuroplasticity is, but I'll just give you an explanation that the brain has an ability to create more functions in different part of the region if a specific part gets damaged, and it can rearrange those functions in different regions, and it has the learning capability to create new memories. So that's what we are trying to do here, is train the brain again and again with the information to create a new memory. So we measure these things. You drag and drop, you get a right or wrong answer in the family tree. Same with events, like you ask them which year was the graduation, or when was this picture taken or something. I would no idea because it's a demo. So when was this granddaughter's birthday, which year? So this thing juggles. Sometimes it's the picture you need to match. Sometimes it's the year, sometimes it's the description. And the second one is visual tools. We look into colors and identifying colors and short-term memories and stuff. So this is like you need to just remember what kind of light flashed, and you just have to pick this up. There are 4 to 5 games in each categories, each looking at different cognitive parameters. So in decision making, we look at certain things like normal games like Sudoku, math puzzles, building blocks. So like simple Sudoku with simple puzzles to solve. And the next one is my most favorite one, is like daily tasks. So we have recipe, gardening, shopping. So in a make a recipe, we ask them to make a recipe based on the instructions. So the idea of designing these set of games is to say, if they can practice it through gamification, can they just implement this in the real time? Can they identify their food or a teacup? Can they identify and do it in real time, in real life, if they can practice these things quite often? Yeah. So that's the idea of it. And we have gardening. We ask them to do gardening. Just in this particular game, we look into 2 things. One is on the orientation, whether they can place those seeds in the right directions as instructed, but also it helps them to do things that will encourage them to do go out and do as well. And the next one is spatial time. Here it's interesting. So we made games to like construct a clock and do set of times. So if you look at the specific game or like construct the clock, sorry. So basically construct a clock is a dementia test that is used for diagnosis. But the whole idea we're trying to do here is to see if people can practice this NF, would they be able to do it against the test? And would that test fail? It's just an experimental thing, but we're trying to aim to train their brain to understand the clock and time and stuff, which are early symptoms. And the last one is language, where we look at objects. We simply wanted them to name an object. I'll get that again. Like simple objects that are in daily uses, like water, rabbit, car, simple things. So these pictures will keep on changing as they play the games every time. So this is like identifying general things like mail, post, daily things like keys, how a key would look, something similar. So these are the cognitive sessions. In the physical, we have little physical exercises that we encourage people to do. These are not heavy exercises, but very light ones. And in emotional, we have meditation. We use different kinds of meditation. And my song is the pictures that they've uploaded, which are their favorite ones. So in meditation, we look at different types of meditation, like hypnotic meditations or breathing sessions, whichever the person feels comfortable. And at the end, we have behavioral questions where we ask set of questions to the user on a daily basis and where we score it. These are general questions on a daily basis about their mood, about their food, about their daily activities. So this will give an idea over time how the user is feeling, and we can get a lot of behavioral data with these kind of questionnaires. So once this is played, right? So coming back to the portal again, this is where the user or the parents or the carers or the GPs find it useful. So we kind of measure certain things like orientation, attention, memory, language, reaction time. So in memory, we look into long-term memory, short-term memory. So you can see if the user's graph is going down or going up. So you can see over a time if there is an improvement in their memory. And we go further deeper, and in long-term memory, we measure episodic, procedural, somatic, and visual memory. So anybody could see which specific memory is declining, and we would recommend to play those kind of games and focus on those kind of games rather than the ones that are really working well. For example, here the working memory seems to be good because it's progressing. So the focus would rather go to episodic or procedural memory, like following the instruction games to improve the procedural memory kind of thing. So this kind of really helps a GP or also even the carers to understand where the focus has to be. And same with the behavioral report, we kind of see what kind of activities on the sleep, food, and the mood, is the graph improving or declining, which can tell a lot of stories. We're also planning to have a personalized report based on the personalization, which if the user continuously rejects a family member or certain era, time period events, then we can give personalized report to carers to stop talking about those particular era or events, or if they are in the early stages, try to train them with the memories of that certain era. So we can help with more information to the carers to help the patient improve, or if they're declining, then we try to help them to have a much better behavior from the carer side to take better care. So that's the demo on the app. And coming back to the we have clinically validated this. So we had 3 clinical studies, and one is a randomized clinical trial with 60 dementia patients, early dementia patients, and we have 3 papers published on it. In nutshell, what we found is we had 2 groups basically: mild cognitive impairment and early Alzheimer's patients. In mild cognitive impairment patients, we show improvement in motor skills, visual memory, and attention and orientation within 14 days of using the app. Whereas with people with Alzheimer's, we saw improvement in attention and visual memory on the 25th to 28 days on average. So the study only took place for 30 days. So we plan to do a 1-year study to see a long-term impact. And we also did studies on emotional impact. And what we found was very interesting. People, when they used the app only once, the negative emotions massively reduced. So we know like the negative moods of the users who were playing it was reduced compared to the improvement in the positive moods. So that we saw was a good impact of this app. What we are currently developing now is an headset, a brain headset that people can use at home where we measure brain activity. So what we are doing is we are developing AI models. We are collecting the cognitive data from the app and the brain data while they're playing the games. And over a period of time, we are going to scan the brain and see which part of the brain is getting activated or deactivated. So once we figure out over a 4 to 8 weeks time that certain part of the brain is not firing up, then we automatically change the games for an individual to show certain cognitive games that can improve the certain cognitive functions that are related to the region of the brain that is not getting fired up or deactivated. So we personalize the gamification using the brainwave activity. So that's what we are currently in development with. So for example, once we measure the brain activity per game, for example, this is a mapping we did on a family tree for a particular patient or a group of patients we did. So if you see here, you can see the blue part of the region is the deactivated part of the region, and the red part is the most activated region. So with these, we would know which, for example, for a particular patient, if there is a blue activation in the temporal lobe, then we know their learning ability is declining. So we would change the gamification towards more of learning new things. Whereas someone, it could be simply anxiety and stress, then we would forget about cognition and focus them on more doing physical exercises and meditation. So that's what we are currently developing. But the app is currently available in the market. And if you have any questions, please let me know.
Kartheka, the great. Thank you so much for that. So basically, guys, any of you who have any experience of me coming to do cognitive work with you, Kartheka has taken that, all of that evidence, all of that research that says these are the things that work. And she has research also that shows you that her app works, you know. In dementia care, we're used to saying, okay, well, we're happy if we just delay progression. Kartheka's app, as it's formulated, actually is showing that you can have some improvements. And Alexia also said that we do know that there is learning in people who are living with dementia. It is just different, and it does take a little more effort. So something that is so tailored to an individual, and especially in this time in Jamaica, where we and in the region where we're still so very concerned about COVID, we're still facing a lot of restrictions in terms of being able to interact in groups. Kartheka's solution is beyond fantastic. And as I said, shake it from me. I spent a whole year doing a master's on the stuff that Kartheka has condensed into one app that you can purchase it, and you can also get her, she's developing her headset, so you can also get the headset in so that it's tailored to the person that is playing it. And that's very important, because for me, when I go to a person, I give a report every so often, and it says, well, these are the areas that we need to work on. These are the areas that are their strengths and so on. Kartheka has all of that in an app. It's so fantastic. I can't say enough about this. And there's a lot of, technology, and there's a lot of apps in the app store that claim to do things for your brain or improve your memory. Kartheka really does it. I can tell you that. That is all evidence-based. Everything that she's put in there is proven in research, and that's what Kartheka took and created her app. So I'm really, I cannot say enough about how great our app is. I'm happy to pass on Brainberry's information. I think I believe we developed a mailing list from this, and I'm going to send whatever Kartheka sends me about Brainberry and the app to everyone so that you can look at it and decide if you want to access it. I can't recommend it enough. There's lots of rubbish in the Play Store, but Kartheka's thing is the real thing, and that's why I'm really, really happy that she's here today. It's no trial and error stuff. She's put a lot of work into it.
It took us
And
3 years to bring the app even to the App Store. There was like quite a
yeah,
lot of research before we got it into the App Store.
yes, it's a real deal. I'm telling you guys for sure. So not to be too much of a sales pitch, but I'm so excited about it because when I saw that, I thought, great, this is gonna make me extinct as a stimulating therapist. And I'm happy to be made extinct if it means that we have improved outcomes. Okay. So that is, and it won't make me extinct either, but that's another story. And as I said, this guys, this is important work. It is not work that you're gonna find anywhere else. I'm telling you that. So please, as I said, I for sure will make Kartheka's information available. Does anyone have any questions for Kartheka on her wonderful technology? Feel free to stick it in the app. Keisha Smith asked, what is the cost for the app and how do we get in contact with Kartheka? So Kartheka,
Okay, it's
share your
available
screen.
on a website, which I'll share. It's £20 per month on a subscription. And we usually recommend at least ask the users to play 4 days a week. At least 20 minutes. They don't
So
have to play all the games. Anything they like, just 20 minutes a day is
yeah,
highly recommended to keep the brain trained. Yeah.
20 minutes, 4 times a week as a minimum, £20 for the subscription you were saying. And it is available on a website. What's the website? Can you put it in the chat? Do you have access to the chat? Stick it in the chat so everybody can copy it down, but say it out loud if you can so that they can also hear it. What's the website it's available on?
Therapy.
I think Kartheka's sticking it in the chat. Winsome and Tanya, I'm coming. I'm so sorry to wear a bit. There we are, cosmotherapy.com. So everybody run over there. I'm really serious. It's great stuff. And as I said, this recording is gonna be made available for free so that everybody can get that. And I'm gonna post some stuff from Kartheka on the site because you guys on my social media pages. Because as I said, I'm really conscious we're talking to a region, we're not just talking to Jamaica. And there are lots of people who don't have any access to what Kartheka is offering, and it can make a really huge difference. So Kartheka, thank you so much for coming. When I met her, I was like, can you do this with me?
Sorry, Debra, can I add
Kartheka
one more thing which I forgot to present? So,
please,
so with
please.
the portal, it's not only one person thing. We have developed it for organizations like GPs,
Yes,
so they can see the list of their patients in the
yes,
portal. So it's not like a one person thing. So if they buy a bulk license, they can see all their patients' reports within the portal. So it's available for
excellent,
an organization to buy it as well.
excellent. We need to hook you up with the MAJ and so on, which is that's Medical Association of Jamaica. We need to hook you up and get you in a business meeting with them as well, because I know our GPs are very, very keen to be able to better assess cognition. So that is really, really useful stuff. So cosmotherapy.com, guys, please check it out. Kartheka, thank you. Hang out if you want to go and sleep if you don't. She's up very early in the morning in the UK to do
No,
this.
actually, you're wrong. It's in the evening. It's evening. We are ahead.
I thought it was in the morning. That's why I was like, oh my God.
No,
I
you
used to
said
have to get up
morning.
at
So I
5 in
got
the
up at 5 a.m. and suddenly realized I put what's the Jamaican
got it
time
wrong. I'm
So I
terrible
realized,
with the time difference. I'm horrible with it. So I'm happy it's in the evening and not 5 a.m. because that's what I thought it was. And I was like, and I think it's like 5 a.m. But she's still turned up. So thank you so much for that.
thanks,
So if
Debra.
there are
Thank you
no
so
more,
much.
just feel free to hang out if you want. I'm just checking if there are any more questions. No. So you have the information about how to get in touch and you have the website address. Thanks, Kartheka. And I'm going to Tanya. Where are you? We're going to move on to Dr. Tanya Edwards and then to Dr. Winsome Christie. Thank you both Dr. Christie and Dr. Edwards, who I know are super, super busy, for hanging out because we are running late. I really appreciate your patience with this meeting. And let's try not to keep anyone any much longer. So next up is Tanya Edwards. Tanya is, I don't want to, let me not say where I know Tanya from, because Tanya is another person that's really, really dear to me. She's a great get it done person, and she's also super helpful. She's really been very supportive to me since I came back about 8 months ago. Tanya gave me everything she had off the bat, but this is not her introduction. Let me give you her proper introduction. And so Tanya can go ahead. So Tanya is, here we are. She's a lecturer in the field of geriatrics and gerontology at the University of the West Indies, Mona. She's also a team member for Mona Aging and Wellness, and which is located, as everyone should know, on Mona campus, the one in Jamaica at least. Tanya also works as an emergency room physician at the Medical Associates Hospital. She holds an MBBS, a Master's in Public Health in Gerontology from the University of the West Indies, and a Master's in Gerontology and Geriatrics from the University of Malta. Anyone who works with aging in any way knows that the University of Malta is a gold standard. Malta itself is a gold standard for geriatric care. So very, very pleased and proud to have Tanya here. And I've asked Tanya to talk about managing the dementia patient in the emergency room, because many people are going to end up in emergency rooms with people living with dementia. And we would like you to have this practical information. So Tanya, without further ado, please go ahead and give your presentation.
Thank you, Debs. Thank you for that introduction, and thank you for the invitation to speak. Can you see my slides?
Yes, I can.
Yes, all right. So good afternoon. No, good afternoon, everyone. So I'll be looking at managing the dementia patient in the emergency room. And we have heard a lot about dementia. And so now is seeing how we manage them when they come into the acute setting, especially the emergency room. And this will be the outline of my presentation. So looking at the overview of dementia, cognitive impairment of dementia, looking at the typical ER, the setting, the design, persons living with dementia in the ER, and looking at approaches to managing the dementia patient. So what is dementia? Just an overview. Dementia is actually an umbrella term encompassing a number of progressive brain disorders. And it's basically diagnosed when there are 2 or more problems with brain function, particularly language, memory, perception, emotional behavior, and personality, cognitive skills, such as calculation, abstract writing, and judgment. And memory loss is usually the first symptom to be observed. What are some of the signs and symptoms? And these may include slowly progressive loss of memory, judgment, intellectual function, personality changes, decrease in movement, sensation, speech, hearing, vision, and other brain functions. There's also disorientation to person, place, and time. There may be language challenges as well as depression. There are different types of dementia already mentioned, the commonest being Alzheimer's, which contribute to 60 to 70% of cases. There's a vascular type, the mixed type, as well as a Lewy body type dementia. And in terms of the global prevalence, just a quick overview. Currently, more than 55 million people have dementia. Over 60% live in low to middle income countries, and every year there are nearly 10 million new cases. In fact, dementia is currently the 7th leading cause of death and one of the major causes of disability and dependency among people globally. And in our local context, dementia, the prevalence of dementia was found to be 5.8 and 5.9% in a study carried out by Eldemire Scherer et al. In 2018. And the Alzheimer's pattern dementia accounted for 61.8%. Vascular dementia, yes?
Go to slideshow. I'm just seeing your first slide.
Oh, I'm not moving? Okay.
No, I think because you're not in slideshow, I'm seeing right the screen but not slideshow.
All right, let me.
Yeah, because you're saying some really great stuff, especially about the prevalence and
All
Dr.
right, let
Sherr's
me.
research.
I'm gonna stop share so that, for a bit.
And maybe reshare again. Because PowerPoint and Zoom, they don't seem to like each other. I know the problems with it as well.
Are you seeing it now?
I'm seeing it, but can you come into slideshow so that you can just click click the top, or you click slideshow at the top, or yeah. Left.
Yeah.
And see if that will do it, because mine
Let's
wouldn't
see.
this morning.
Is
There
it
we go.
moving now?
It's moving, but it's not in slideshow. I think that's something with Zoom, because it wouldn't move it wouldn't work for me this
I'm not
morning
sure
either.
what's happening. Yeah.
No, that's okay. Just progress them as it is, because we can still see the content on the slide. It's just not
Okay.
blown
All
up
right.
on the
Sorry
full
about
screen.
that.
No, no problem. It happened to me too. Go ahead, Tanya. Sorry about that.
Okay. All right. No problem. So I'm going to go back to prevalence in the local context. All right, so let me just start over with that one. So as I was saying before, the dementia prevalence in the local context is 5.9, as found by Eldemire Shearer in 2018 in a research that was done. And the Alzheimer's pattern dementia accounted for 61.8%. Vascular dementia accounted for 32.4%, and vascular disease was prominent in 45.5% of the Alzheimer's cases. Vascular disease meaning hypertension and cardiovascular diseases, including diabetes mellitus. Importantly, female gender and increasing age were associated with higher rates of dementia. So looking at the cognitive impairment and the ER, between 21% and 40% of older adults who present to the ER are cognitively impaired. Of this, 21.8% usually screen for dementia without delirium, while 40% are positive for any cognitive impairment, including delirium. Very high percentage for those who present in the ER. So persons living with dementia usually visit the emergency room for several reasons, including after-hours care, urgent prescription refills, acute medical needs, triage of trauma-associated injury, assessment of new symptoms, caregiver reassurance, and caregiver desire for a person living with dementia's admission, meaning they feel very overwhelmed, that is the caregivers or the carers, and so they just want a rest. They want to just be by themselves. And so they will come to the emergency department begging, asking for the persons to be admitted, even for the night. I think it's very important that we understand the typical emergency room design or environment. By nature, the emergency room is a chaotic place. It's very fast-paced. The environment can make it even more confusing for a person with cognitive impairment. The noises of patients in pain, shouting sometimes, persons being impatient, machines beeping, overhead pages can cause an even more chaotic environment. And the constant movement of people in and out of rooms create an ideal environment for the expression and exacerbation of behavioral problems of dementia. And so you have the environment, which is important to understand the setting of the emergency room, but also the disposition or the attitude of the emergency staff is very important. So emergency staff have reported feeling burdened by persons living dementia. the very fact that a person with dementia has entered the emergency room just bring about a feeling of just, I can't manage this, I don't know how to manage this, and so they feel overwhelmed. Older adults require additional time and resources, and again, as I said before, emergency room is very fast-paced. You want to see this patient, you go to the next patient, you get things done and out. And so for older adults, especially with dementia, coming into the emergency room, the staff, it really challenges the staff in terms of, patients requiring time and also the resources. Older adults' cognitive impairment acts as the greatest barrier to providing the best emergency care. And these are the reports that emergency staff members will give. They also report the need for continuing education about cognitive impairment in older adults and persons with dementia, their family and caregivers, and also emergency providers report negative impressions of the emergency encounters, meaning after they have encountered or have dealt with or managed a person living with dementia, the parties are not satisfied. So the emergency staff members, they're not satisfied with the level of treatment or management that they provided, and usually the family members aren't satisfied as well. And so often dementia, sadly to say, often dementia and the ER do not mix successfully. The ER experience is vulnerable to a rapid escalation of risk, meaning the person with dementia can come in very calm and it moves from 0 to 100 or 100 to a 0. And so it's a place where the risk increase because of the chaotic nature or the fast-paced nature of the emergency room. Dementia actually lowers the threshold for sensory overload, distress, and disruptive behaviors. Again, the emergency room is fast-paced, overwhelming, even to the cognitively intact individuals. I'm not sure if any of you have ever been into the ER and, people are shouting, they're impatient, they want to be seen now. And so, some person, they can't navigate in that busy, cognitively intact individual, can't navigate properly in that kind of environment. And so it is understandably difficult for emergency staff as well to slow down. Sometimes it's hard because you're used to, going. And so to slow down when somebody comes in with a history of dementia is very hard and is a challenge for the staff as well. And so even though it's hard, even though it's a challenge with person with dementia being in the emergency room, the approach to persons must be in a calm and reassuring manner. The staff should slow down their pace and speech. So now it has to be deliberate. Simple language should be used. The ER staff should consider what a frightening experience emergency room is for older adults with dementia and also without dementia. And it's, empathy is very important here. So the persons who work in the emergency room should envision, how the person living with dementia sees the emergency room through their eyes. And so that will help to determine how we adjust our bedside manners and how we approach these persons living with dementia. Unfortunately, there are some disadvantages in having person with dementia in the ER, especially because not a lot of persons or not a lot of the medical professional in the emergency room are trained in geriatrics, and not many are trained in the area of dementia. And so dementia in the ER may contribute to inaccuracies in the medical or medication history, difficulties gathering a history of the present illness, and inability to comprehend and follow complex discharge instructions. Again, because it's so fast-paced, you want to get things done. You want the person with dementia to actually align themselves with your pace, and that cannot happen. And so this may result in negative clinical outcomes. So how do we approach the management of the person with dementia in the ER? It's very important to do several things. For example, assessment, communication, looking at adverse events that can take place in the ER, physical environment, as well as looking at the staff education. And I'm going to look at each one. So in terms of assessment, it's important to use standard cognitive screening as a strategy for recognizing dementia in the ER. This is not usually done. Usually we know that person has dementia by the fact that the caregiver or the relative will state that this person has dementia. Or after a while, we realize that the person does have dementia because they have now gone into a very aggressive behavior in the emergency room and say, oh, I think, based on the behavior, I think this patient has dementia. And then you confirm it with the healthcare, with the caregiver. It's important to incorporate assessment of cognitive functioning in the ER. And this should be part of the skill set of any emergency physician or emergency worker. The ER physician's recognition of dementia may result in good quality of care, delayed and misdiagnosis may be avoided. The opposite is true. If the emergency physician cannot recognize dementia, then it will result in poor quality of care. And of course, you'll be delayed and misdiagnosis. There are some important questions that must be asked. I must say that when a person with dementia comes into the emergency department, it is not just the patient that is being managed. The family members must be involved, the caregivers must be involved, the patient must be involved. So you want to know who brought the patient in, where had the patient been, how did the patient arrive at the ER, who is the caregiver, do they have any dockets or medical records? You want thorough information, especially medical information about the patient. Always involve the caregivers, whether formal or informal, and very important, slow down. In terms of communication, this was touched on earlier in the presentation. The use of simple one-step commands and repeat as necessary. The caregiver should be in front of the person, maintain good eye contact, use appropriate pace of speech, should be slow, soft voice. Oral or written information provided to the person with dementia should take account of their disabilities. So not going to write something and then they can't read it, or it's too small, or they need to use glasses, or they have lost the ability to read. And very important, do not discuss the patient as if he or she is not in the room. So often, you start talking to the caregiver, totally ignoring the patient. And so we will say, how is Mrs. So-and-so? And you're not maintaining any eye contact with the patient. And you say, can she feed herself? Can she walk? Can she talk? And she's in the room. So involve the patient always in the conversation. Also, in terms of communication, please avoid terms of endearment. So it's called elder speak or baby talk. So don't refer to the older adults with dementia as mommy or daddy, grandpa, nana, papa, sweetie, baby, or little girl, because you want to treat persons with dementia and any human being for that matter with dignity. And so part of showing them dignity, treating them with dignities, addressing them by their name. I'll give you an example. There are persons who come into the emergency room and they will say, mommy, and you're like, I'm not a mommy, I'm not your mommy. But once you call them by their name, say Mrs. Wilson or Miss Falloon, then their attitude completely changes. Their attitude will change based on the fact that now you're speaking to them and they feel that they're part of the conversation as well. There's actually a study that was done in 2009. It's an old study. It's an observational study conducted by Williams et al. And they found that when older people living with dementia are addressed by the nursing staff using elder speak or baby talk, the behavioral change is often negative, resulting in aggression, agitation, and increased wandering, which is referred to resistiveness to care. As a matter of fact, they found in the study that the turnover rate of healthcare workers was very high because of this aggression, which is because the healthcare workers were referring to the older adults by elder speak. They were talking to them and like they're babies. So they would call them Nana, mommy, grandma, grandpa. And they also found that when they're addressed by their profession, for example, if there's a retired doctor or retired teacher, then their attitude changed in the positive. There's some adverse events, and these adverse events actually occur in the ER, common adverse events while in the ER, and these adverse events will result in poor outcomes. Again, sometimes during the triage phase of seeing the patient in the emergency room, instead of giving them a higher number in terms of the triage or importance, is called ASI, instead of giving them an emergency number, for example, they put them next in line. And so what can happen is that they may result in dehydration because they may have to wait until their number is called or they're next in line. And that may result in dehydration, infection, the use of antipsychotic use because of aggression. So now they're sitting too long in the emergency room, they're in a bed too long, the place is strange, and now they're getting aggressive because they're frightened, they're in a strange place, and they want to go home. Poor health utilization outcomes, meaning they were brought, the persons living with dementia may have been brought to the emergency department for a particular reason or medical illness, and because of the aggression, the impatience, they're not being seen quickly, then the relatives, the caregivers may say, you know what, I'm taking her home or taking him home. And so there's poor health utilization outcomes. They don't get optimum treatment while in the emergency room. And also return visits. So they will leave and they will come back for the same complaint. They will say, you know, I came last week and he was just behaving badly, and so I had to leave, and now I'm coming back for the same issue because it has not resolved. And so in terms of avoiding these adverse events while in the emergency room, there's some appropriate intervention that can be included. And these are encouragement of oral fluid intake, pain reduction and recognition and management, frequent and feasible toileting opportunities, and also allowing for wandering opportunities. Sometimes they just want to walk outside and want to get some fresh air, and you want to say, just stay in the bed, you can't move. And so it's very important to, you know, approach them in terms of a patient-centered approach and understand the needs of older adults with dementia. Delirium is a very important topic when we talk about older adults, and particularly older adults with dementia, because they will come into the emergency room, maybe they're very energetic, aggressive, and so you want to be able to decipher whether this is delirium or whether this is just an exacerbation of the dementia. And so delirium is an altered state of consciousness characterized by episodes of confusion that can develop over hours or days. So what I would ask the caregivers or the relatives, I would say, is this a new confusion, or this is his usual behavior? And if they say, no, this is not, you know, he's usually calm in the evenings, but no, I'm not sure, he has never been like this, or he gets aggressive, but this has gotten worse. You want to find out the cause of the delirium. And also to realize that this diagnosis is a delirium and not dementia. So delirium is actually a syndrome and not a disease, and it may manifest as verbal and physical agitation, leading to the use of antipsychotic medication and physical restraint. Delirium can be treated once the offender or the offending cause is identified. And most common cause of delirium in older people is the use of medications, and especially routine medication. So very important to ask them, the caregivers, have they started any new medication? And based on that, you know, this is delirium as well. And once they have started it, and the time in which the delirium, the onset of the delirium, you know, that is the medication. And so common medication prescribed includes psychoactive agents such as benzodiazepine, narcotic analgesic from morphine or codeine or tramadol, and drugs with anticholinergic effects such as DPH, Benadryl, and Aleve PM. A lot of the cough, quite a few of the cough mixtures, and especially the ones that will make you sleep, can cause delirium as well. And so it's very important to identify the cause of it. Some other common triggers of delirium include acute pain, medical illness or infection, infection ranging from whether it's a chest infection, a urinary tract infection, can cause delirium, immobilization or the use of physical restraint, urinary retention or urinary catheterization, dehydration can cause delirium, environmental factors. So now they're moving from an environment that they're used to, they are familiar with certain voices, certain sounds, and now you take them into the emergency room. They're hearing voices that they're not able to identify. They're seeing objects that they're not familiar with. And so this will precipitate the onset of delirium. Alcohol and drug misuse, you want to know about that, and psychosocial factors as well. I give an example. There was one older gentleman who came in and has a diagnosis of dementia, and he was very calm and who had wanted to do a procedure because he had not, well, a procedure. He hadn't eaten for days. And we were trying to get an NG tube in. And we asked the relatives to stay on the outside, outside mean not immediate outside of the room, but far outside. And he started to get really aggressive. And I remember a nurse was saying, for example, his name is Mr. Campbell. I was like, Mr. Campbell, pretending that that she was his daughter, and he was like, I don't recognize that voice. I don't recognize that voice. And so we couldn't, he was not cooperative because he didn't recognize any of us. And he was saying, I have never been in this situation before. I have never been in this situation before. And I think our mistake in managing Mr. Campbell was that we did not include the family member. They should have been in the room so as to decrease this, this aggression and aggressiveness. The truth is, the emergency room, the physical environment and design of the emergency room, though it tends to be age-friendly now, is not specific to persons with dementia. The emergency room is often an open space design, effective for care of the acutely ill patient. And the design produces a bustling, overpopulated, noisy space. And sometimes persons are shouting, you may have an emergency. And of course, when there's an emergency, there are shouts, there are people running everywhere. And so very, really hostile, I can quote unquote, to persons with dementia. And so it's very important to have spaces, especially in emergency room, that are designed for persons with dementia. So you have a designated space with adequate lighting, adequate space for caregivers, spaces that reduce or avoid environmental overload, spaces located near the nurse's station, consistent staff member to assist the patient in navigating the space, stimulus reduction and continuity. Continuity meaning there's one nurse, there's one doctor, there's one healthcare professional that's assigned to taking care of the person with dementia, just to establish rapport, and so decrease the stimulus, because increased stimulation will again cause the onset of aggression. And shorter lengths of stay in the ER with appropriate disposition sites, whether they're going back to home, going back to an institution, or they're going to be admitted. So it's very important that persons with dementia, once they get into the emergency room, that they're not put next in line. They should be priority case. And there should be a space designed for them, and a nurse or healthcare professional assigned to take care of this patient. And this is a diagram or picture showing, some of the environmental modification in the ER. We have better lighting, soundproofing, non-skid walk surfaces, pressure reducing mattresses and cushions, availability of visual aids, hearing devices, adaptive equipment, and appropriate ambient temperatures. Education of staff education is very important, especially when dealing with persons with dementia. Staff education remains a primary tactic to change staff behavior. Earlier in this presentation, one of the reports of the staff, the emergency staff, is that they don't feel equipped or prepared or trained to take care of the person with dementia in the ER. And so staff training session in screening for dementia and delirium is very important. Educate staff in order to reduce discrimination and also to improve management of disruptive behaviors. I thought it was very important to put in elder abuse in person with dementia, especially being seen in the emergency room, because sometimes you can be suspicious about it, especially when there are frequent visits to the emergency room for injuries, exacerbation of chronic illness, poor medication adherence. So they may bring the medication, or they may bring a prescription, and you realize, but this prescription is expired, or the person is out of prescription, out of medication, or if there are frequent visitors to the emergency room, you can actually look on their medical report or medical records to see that you did prescribe medication last week, but now they're out. So something is going on. Poor compliance with routine medical care can also, bring about suspicion about abuse. Unkempt appearance, so they come into the emergency room, the clothes is dirty, they're ragged, and so you wonder what's happening. And also suspicious attitude of caregivers. Of course, if you see all this, you're not going to say this is elder abuse, because you have to, investigate and do a thorough history of the patient as well as a caregiver. And that's why it's very important to always involve the carers, the caregivers, as well as the patients. And there's I want to look at some appropriate approaches to the person with dementia in the emergency room. So pre-arrival plans, very important that the historian or the caregiver, because usually it's the caregiver or the relatives that will give the history, the presenting history, the medical history of the patient. So it's very important that they know the information well. If not, it's important to write these things down, have a docket, have a record. It's important also to notify the emergency room of impending visits, so that a room can be prepared, or a nurse can be assigned, a doctor can be assigned to this patient, and for them to know that once this patient, we're expecting this patient, and once he comes in or she comes in, they don't have to wait, they don't have to go through the long process. Just put them in a room and we'll start, because we want to get them in and out as quickly as possible. Have all the medications. You may not be able to know them by name, have them written down. Again, good medical history and records, very important. Take the patient's medical files or records if coming from an institution. And while they're in the department now, it's important to decrease the stimulation and improve communication between clinicians and the patient and the caregivers. And so, as I mentioned before, it's important to assign the same emergency staff member for interaction, treatment, assign an individual room for them to be in. And ER-based strategies of faster triage must be implemented, private space and other environmental modification. Again, it was mentioned in one of the presentations about not saying, oh, you said this thing already. I always, tell my colleagues, live in the reality of the person with dementia. So if they say to you, oh, you look like my granddaughter, I say, yes. Or they say, oh, what's your name? And I was like, Tanya. And it's like, Tanya, is that you? Yes. And they say, oh, long time I don't see you. Live in that reality, because then you can get as much out of them and you can treat them effectively. Limit or no use of both sedation and physical restraint. Don't want that at all, because that can make the outcome worse for the person with dementia. The use of distraction aids and analgesic gels during procedures. For example, we have to put in an IV access, then they will fight and they can be strong. Person with dementia can be very strong sometimes. And so to make their experience as smoothly as possible throughout being in the emergency room, the use of nonverbal pain scale to guide assessment of pain and treatment. From how I would assess a patient with dementia, of course, use very calm, soft voice. And I would start palpating before I even put on my stethoscope on their chest, just to see and just keep observing their expression on their faces to see if there's any pain. And if I press on the lower abdomen and they will, give a little twitch, I realize they may be having a urinary tract infection. But be observant to the changes. If you ask them, can you walk? And it's like, yeah, I can walk. It's okay, stand up for me. They're walking with a limp. Then there's pain in the hips. And of course, you have to get a detailed history of why the person's in the emergency department. And that's it. Thank you.
Tanya, thank you so much for that. I'm so pleased that Tanya was able to spend the time. I hope that the audience sees what it really should be in terms of the management of a person living with dementia in accidental emergency. If anyone has questions for Tanya, please feel free, or from Melissa. I'm also have Melissa waiting from the physiotherapy talk. If anyone has any questions from Melissa around the training of balance and the training of joint sense, etc. Tanya, I think, did a really, really one thing. If you leave with nothing else, leave with two things. The use of sedatives and antipsychotics in dementia, people living with dementia, is really, not to be encouraged. It's really a last resort thing, because it increases confusion. And with the antipsychotics, there's a lot of research coming out of the UK that says it increases the risk of death in people living with dementia. Thank you for correcting. I keep thinking, whenever I talk about dementia, I always say vascular dementia is most common. But what it is what Tanya said in the research because I'm taking that from Dr. Shiver's research. What it is that the underlying cause of the mixed dementias and also the vascular dementia often is non-communicable disease issues, a lot of which are risk factors for vascular dementia, in addition to the prevalence of vascular dementia. So it becomes very important for us in the Caribbean in terms of the management of non-communicable diseases, because that, I think, would probably lower a lot of prevalence and incidence for us. The other thing that needs to be said, so the sedative stuff is one. Delirium, I really asked Tanya to leave that in and discuss it, because we also need to know the difference between what we would call an acute confusional state, something that comes on, as Tanya says, over hours or days, and something that is a dementia. It's not usual that dementia comes on quite suddenly. And the other thing I would just say on delirium, Tanya, if you'll allow me, is that look out for delirium post-surgery as well. That's not an emergency room thing. Obvious. I mean, rarely is somebody bouncing into the emergency room post-surgery. It can happen. But for the caregivers and so on listening, please be aware that post-operatively, that delirium can spring up as well, that level of confusion. Tanya, I have a question for you, and then Winsome can start. I want to know, from your talk, I've gathered that a caregiver should, probably have the prescriptions for the person when they're heading to emergency room. They should really try to stay with the person if it's a person living with dementia, so that the doctors have them as a resource, and they should be prepared with whatever documentation they can give to the accident and emergency physician. Is there anything else that you would like, or is there a checklist that you would like them to bring when they're coming to see someone in an emergency room setting? Just from the other side of things, because we've seen the doctor's side. From the other side of things, what would you love to see from a caregiver when you're gonna come to a person living with dementia?
To be honest, what I usually see in the emergency room with caregivers is that a caregiver will come who has no idea what's happening with the patients. They will say, "Oh, I don't work on the weekend. I only work during the week, or I'm just doing the shift for somebody else." So it's very important to document every day. Bring everything that you've documented: the blood pressure, the GMR, everything, what they have eaten. Another thing, Deborah, that I didn't mention is constipation. Chronic constipation can result in delirium as well.
Oh, Lord. That's a big one. Yes.
So bowel movement is important. When was the last time?
Yes.
Urinary tract infection. I did mention urinary tract infection. And
yes,
also,
you did. UTIs
coming into the emergency department, again, not many of the emergency room physician and staff members are trained in dementia or geriatrics or gerontology. And sometimes it's also a time to teach. It's a patient education session. So you may say, "Oh, I think this person has a urinary tract infection." And they say, "But I can't test it because they can't go to the bathroom to pee." But a trick, I found out this trick is that if they have a soak diaper, just use a strip and press a strip on it and you get the result.
Nice.
So you teach them all these things out well. And, what I will also teach them is that it was Alexia who said, don't say that you've said it before. Live in their reality. I'm the granddaughter for so many people.
It's true. Just don't argue with them. It might not sound sensible to you, but don't argue with them and try to go into whatever they are saying as opposed to trying to contradict them. That is the most. If everybody takes that from this today, that would be a blessing. I have 3 questions here. One, I'm not sure what this means, but it says recommendations for getting a CT scan or an MRI done, ? Any alternative ? If you're talking about dementia, that I'm from when in my training, we don't MRIs and CT scans are really used to rule out a lot of other things usually. Because again, a tumor might be causing an issue. It might be some level of, I'll let Tanya answer, but and I'm not sure that there's an alternative to getting that done because it's such a valuable piece of diagnostic in terms of ruling out other things. But Tanya, would you want to answer in terms of, is there any alternative to doing a CT or MRI scan to rule out or rule in dementia?
So usually when in the initial onsets, that you're working up the patient to see if they have dementia, because you don't want to just tag on a diagnosis. So usually we'll recommend MRI to see brain changes and also to rule out other things, because you may have acute fusional state, and behavioral
Right.
changes that can occur, as Debbie said, from a tumor or anything else. Blood tests we will do. CT scan, not so readily. In the emergency department, of course, we're not going to recommend MRI and CT scan unless, based on the history, there's some focal deficits. So they realize one arm is not moving, there's facial twisting, there's drooling, which is evident that they may have had a stroke. Then, of course, we'll do a CT scan. But if a dementia person with dementia comes into the emergency, that's not going to be on top of our list.
Highly unlikely.
Yeah, it's to identify the problem, get them out as quickly as possible, because they can escalate.
Yes, and I think it's important. I'm going to repeat it because I think people really don't remember that accident and emergency physicians are not general practitioners. They're coming to you to try and figure out what the acute situation that you've turned up there is about, and they're trying to make sense of it really quickly. So I think someone who has, the person who asks about CT scan and MRI, if that's coming from, say, a psychiatrist, a neurologist, or your GP, you might want to ask them why they've asked for that. But as I said, it is a part of the diagnostics for dementia, because as I said, we have to also rule out things. There are many things that can be confusional. Nicole says she wants to see the slide again on the medications that may cause delirium. I would say anticholinergics are like number one.
Yes. Cough mixtures.
But we have a pharmacist coming next. Tanya is going to put up the slide again, but we do have a pharmacist coming next as well. If a patient has dementia and is bedridden, Melissa, where are you, Melissa?
I'm here.
Okay,
yeah.
So if a patient has, this is for you. I mean, I'll disclose that in a former lifetime, I was also a physiotherapist. So everybody feels free to come in here.
Yeah.
If a patient has dementia and is bedridden as a result of the progression of the condition, can that patient be rehabilitated, or what recommendation would you give in regards to physiotherapy management? You always need physio, especially if they're bedridden. There's a high risk. But Melissa, you go ahead and answer, because
yes, there's a lot that we can do from a physiotherapy point of view. Let's go as basic as breathing. You want to get this patient doing a lot of deep breathing exercises. You want to make sure their lungs are clear. We want to help with their bed mobility, make sure that they can get in and out of the bed, up and down the bed, left and right in the bed. There are lots of activities that we can do in the bed. So many things that we can do to get them to be as independent as possible in the bed. We want to start getting them to sit over the side of the bed so that they can retrain their balance, get a different position. So we're helping to prevent things like bed sores and those sort of things. So there's a lot that can be done. Your best bet, though, is to have a physical therapist come in and do an assessment so that they can give you ideas. And I mean, very often, from a financial point of view, we start thinking, oh no, the physio is going to come in, it's going to be a weekly bill. That doesn't necessarily have to be the how it works out. Once the physio give you some ideas of to do, because ideally you're the one who's there all the time. So you need to be able to do a lot of these exercises with them, encourage them to do this stuff. Because having physio come in once a week or once a month is not going to make a difference. It's the day-to-day exercises that are what will make it a lot different and give the best effect.
Yeah, I think it's important to say that there's a lot that I think my experience in 20 years, I'm sure Melissa's and Tanya's as well, there's a lot that you don't know that physios do. But always, wherever there is any problem with movement, any patient that is bedridden should be in at least a monitoring relationship with a physiotherapist, because pneumonia is, speaking of delirium, pneumonia is one of those things, and pneumonia also can really, it can lead to death. It can get quite serious quite quickly. And also, as she said, we preserve all sorts of function as physios. I'm passionate because I am a physio, but honestly, it's the truth. This person, moving to the question again, is saying the client goes ballistic when they have to do MRI or CT test. Tanya, you want to offer any suggestions about how can doctors or staff help to keep the patient calm. I think one of the most important things Tanya said before she jumps back in is, please involve the caregiver. Please involve the caregiver. The caregiver knows them better than anyone else, and the caregiver can often offer little tips and tricks and ways to help keep the patient calm. Perhaps you want to keep the patient in the room. Keep the caregiver in the room and so on. With dementia, the caregiver is quite central in terms of making sure that you manage the agitation. Tanya, you have anything you want to add there in terms of how to manage a patient who might be, because MRIs are really difficult pieces of equipment, even for people who don't have cognitive impairment. It can feel like a huge noisy tunnel. Tanya, as I said, is speaking in an acute setting, so I'm not sure. But Tanya, would you have any suggestions for how to manage a client who is having a lot of trauma around MRI? Or to Tanya?
I'm trying to unmute.
Yeah, would you have any suggestions? And then
so for patients who would want to do MRI,
so you were saying that the patient goes ballistic according to her. So I assume a lot of agitation and aggression whenever they have to do like MRIs and CTs.
So I've had to stay in the MRI room with patients just to reassure them that I'm right there, because it's very, I'm not sure if you've ever been in the room. It's very noisy. You have different kinds of noise, and it goes from different speed to different
crazy.
Crazy, and then it moves.
It can be anxiety producing for people who don't have a dementia.
So I've stayed in the room with person with who's cognitively intact as well, those without.
Do you think they'll allow the caregivers in that case? Because MRI
they can, but I guess it depends on where, but they can. They can. It just you would have to go in there with ear protection as well. And they would have and they would tell her the risk of going in there.
MRI has some safety concerns.
Right. So the safety in terms of auditory protection, and also because I've been in there as a doctor, so I would give them a sedative, nothing to make them sleep, but just it's called conscious sedation, so they can tolerate it. And so you monitor right through. So if someone who's cognitively impaired, they probably can ask their GP or if they're willing to stay with them in the room, as well as a caregiver, just for reassurance.
Thank you, Tanya. And now, last but not least, Dr. Winsome Christie is going to present. I'm so very pleased to have Winsome here, and she's been extremely patient because we have run late. All of you have been extremely patient. So let me just say a few words about Winsome and then let her get started, because she's really been extremely patient and I don't want to hold her too long. But it is important for us to, because Winsome is another person that has many, many accolades, many various awards of recognition, etc. And then also, let me just read from the speaker's introduction. Sorry, 1 second. I'm going to just read our speaker's introduction that I had posted for time. Here we are. Wonderful. So Dr. Winsome Christie has over 30 years experience in Jamaica's medical industry. She's both a naturopathic doctor and a clinical pharmacist, and she established Jamaica's first complementary and alternative health pharmacy, which is Sunshine Pharmacy in Maypen. She's both an author and a teacher, and she has collaborated on a medicinal compounding course with a focus on cannabis. Winsome holds a doctorate in naturopathy, a doctorate in philosophy in holistic nutrition, a master's in clinical pharmacy, and a master's of science in holistic nutrition. She's also the immediate past president of the Pharmaceutical Association, and I could go on. She has various honors and awards, and she has appeared on numerous media. She's appeared in media several times because she's quite passionate about pharmacy and about other topics as well, naturopathy, etc. So without further ado, I'm going to give the floor to Winsome. So Winsome, go ahead for me, and thanks for being a part of this. I really appreciate it. I think you might have to unmute yourself though, Winsome.
Okay, am I muted?
Not anymore, not anymore. Go ahead.
Oh, you can hear me, okay.
Winsome?
Yes, can you hear me?
Yes, go ahead. You're not muted anymore.
Okay, great. Can you see my slides?
Yes, I can.
Okay, great. I want to thank Debbie and this fantastic group of persons who are here presenting on this topic that's so relevant for us here in Jamaica and the Caribbean, and in fact, the world. I enjoyed sitting listening to everyone. It was fantastic information, very, very current. So I'm going to speak to you, and thank you, Debbie, for your kind introduction. I'm going to be speaking to you about polypharmacy and its risk to the elderly with dementia. Now, as my other colleagues mentioned before, dementia is really under an umbrella of a range of cognitive impairments that interfere with daily function. So it's not just a single disease. There are different types of dementia. The Alzheimer's, vascular dementia, as mentioned, described by the colleagues before, the Lewy body dementia, based on the structures that's seen in the brain on the scan when they try to perform the diagnostic test. And then you have the mixed dementia. So this is a global crisis that affects the population. And in fact, it's a degenerative disease that disease trajectory is downhill. So therefore, the aims of the specialists and clinicians involved is to slow the progression and improve the outcome for the patient and the family. The medications used in dementia are the memantine N-methyl diaspartate group. This is a receptor antagonist that is used in the Parkinson's type disease, Lewy body, and the comorbid vascular dementia. So it can be used in 3 types of the dementia disease. And donazepam, that can also be used in 3 types of the disease. And trazodone, that's used in the aggressive, agitated behaviors associated with dementia. So because of the trajectory of this disease, there's a need for this new type of treatment, this type of treatment approach, palliative care. In this type of approach that is becoming more popular, and basically the team here have been describing different aspects of this care. It's an approach in healthcare that focuses on improving the quality of life for individuals, not just with dementia, but a wide range of illnesses that has a trajectory that goes downhill. For dementia patients, the service will include pain management, symptom management, emotional, psychological, and spiritual care, which is part of palliative care. For dementia patients, their ability to communicate how they feel, other aspects of their care is greatly diminished. And so the palliative care specialist, which is a team approach comprising of physicians, specialist nurses, physiotherapists, social workers, complementary care personnel, all spectrums of the healthcare are now combining together to try and provide the best care possible for these persons. So when it comes to communicating how they feel as it relates to pain, agitation, sleep disturbance, all of those symptoms need to be effectively managed so that the person can have a better quality of life. Of course, these patients have other comorbidities such as heart failure, diabetes, and circulatory problems. Hence, the need for looking at polypharmacy. Now, polypharmacy is defined as the concurrent use of multiple medications, and this is a growing concern as it relates to the treatment of dementia patients and palliative care for the elderly. Some of the negative effects of polypharmacy involves the medication burden. Because of the many different medications that's been prescribed for the individual, there's a pill burden, which it can be overwhelming for the caregiver, the patient who has to swallow them, and the family members who have to keep buying them. Financially, it can be a burden, as well as keeping up with the regimens. And as a result of the multiple medications, there's also the risk of medication errors and overdosing. There's also the risk of drug interactions, where once medications are working in the same area and being processed by the liver or other areas of excretion, then there's a potential for interruption in the process of the drug, and again, side effects, drug adverse effects because of toxic products building up in the body. And sometimes these drug-drug interactions can cause and worsen the cognitive effects that's already declining in these patients. We look at the cognitive impact for these patients. Many medications, as Dr. mentioned, for example, the ones with anticholinergic effects, these pose a risk for dementia patients because they block the muscarinic acetylcholine receptors in the nervous system, especially those that's important in the brain that's involved with the cognitive function and the pathophysiology of some illnesses like the Alzheimer's, which is a class of dementia. So for anticholinergic agents, even those that treat the Parkinson's disease like benztropine, trihexylphenidil, those medications used for chronic obstructive pulmonary disease, those used for overactive bladder like oxybutynin, other medications such as the first generation antihistamines, which Dr. mentioned, diphenhydramine and others, also tricyclic antidepressants like amitriptyline. These anticholinergic side effects can also worsen the dementia that is trying to be treated. The side effects of these anticholinergic medications include confusion, memory problems, constipation, which of itself can cause delirium, as Dr. mentioned, and also they can prevent the person passing their urine, difficulty in passing urine, which can of itself cause the infection, and infections can cause delirium. So we see the impact of these anticholinergic drugs on these patients. Another problem with polypharmacy is that it complicates the end-of-life care. As a person goes down the disease trajectory and their reception, their swallowing, other things decline, then it's a problem when you have to administer so many different medications. And this will prove challenging for the caregiver and family members, and even the person, the patient themselves, because they will have difficulty swallowing in many cases. And the fifth problem for polypharmacy is for the caregiver, managing this complex medication regimen is a significant burden. And this forces some persons to be practicing deprescribing, which is a feature of how you address polypharmacy. So Addressing polypharmacy, these are the different ways in which the healthcare is being reformed so that clinicians are paying more attention to how they manage patients with chronic conditions that have a negative disease trajectory path. So they perform what is called a medication therapy review. There is a term now, medicines treatment management, MTM, which is can be performed by any clinician who is actively involved in a patient's medication therapy. However, pharmacists are becoming the ones who are being entrusted with this type of activity. And during that process, there's a regular and comprehensive medication review by the health profession to determine if there are any medications present that need to be removed or doses adjusted because it may be either no longer necessary or is now posing a risk for the patient negatively. And then there's this act now of deprescribing. This is the process of discontinuing medications that may no longer provide benefit or may indeed pose a risk to the patient. And in dementia care, deprescribing is now considered a necessary part of the plan. Simplifying regimens. This is now when the slow release drugs are welcomed, when the combination therapy products are welcomed. So instead of you taking 3 different pills for the hypertension involving, for example, a calcium channel blocker, a ARB, that's an ACE receptor blocker, and a diuretic, you can have one product that has the 3 in. And so the once daily regimen would be good for that patient. For diabetic medication, if the patient needs more than 1 or more than 2, then you have the combination diabetic medication that can be given to the patient. You have other drugs coming on the market now that can be given once or twice weekly for diabetes control. Of course, some of these tend to impact the kidneys negatively. So for these elderly patients, they may not be suitable. So of course, pharmacists and the doctors will be working together to see which regimen is best for the patient. But simplifying the regimen is really the aim in these type of patients. And then, of course, there's education. Educating the patients about what's happening to the best of their ability to what they can understand. The caregivers can be educated about the risk of having so many medications and also visiting different pharmacies to fill the prescription. When you do that, then the pharmacist attending cannot get a true picture of what the patient is on so that they can do the necessary medication review or performing a drug-drug interaction assessment using the tools that they have on hand. And also the medical doctor going to different doctors for the patient for different things. That complicates the issues because then you run risk of getting medications that can worsen the person's condition and misdiagnosis. So educating the patient and the client and the caregivers about these different risks is always beneficial. So some tools, I just thought I'd mention some tools that's used in palliative care or in the care of dementia. This first tool is the palliative performance scale. Now this one that I have here, I adapted from the Victoria Hospice palliative scale. PPSV2 version 2. It's designed by the Victoria Hospice Society. And if you notice on this scale, what it does, it tells you the person's best fit for the person
in terms of their activity level. So for example, if they're in a hospice care, you will know how many staff needs to be looking after this patient. If they are full ambulatory, meaning they can move around, or they are bedridden, or you may have to perform oral care on this patient because of where they are in the disease trajectory, whether you need to reduce the food from solid form to more liquefied form, or whether the medications need to be changed from oral dosage form to liquid, well, the oral solid dosage forms from tablets to liquid, or to patches for pain, or insertion, rectal insertions for the pain, or for nausea and vomiting, or other conditions like that. Or if the pharmacist needs to compound the medication so that they can be put into a feeding tube. So this gives you a assessment of where the patient is. And in fact, for palliative care, the team will be aware of where the person is on the disease trajectory using this scale. So just giving you a brief, showing you a brief way of how it's used. You begin at the left column, which speaks about the PPS level, the palliative performance scale level. Then you start in the left column with the ambulation, and you move across the right and downwards to assess each state of the person's state with
functionality.
yeah, functionality. Thank you very much.
Your functionality. We use a lot of scales as physios, so the language comes really easily.
Okay, thank you very much.
A wonderful scale, and you get back out. Go ahead.
Right. So let's look at an example. For a patient now who spends the majority of the day sitting or lying down due to tiredness from the advanced disease and requires considerable assistance to walk, even for short distances, but who is otherwise fully conscious at a fully conscious level, how would we stage that person? So the person spends most of the day sitting or lying down. We look down this ambulation scale, and it says mainly sit or lying. So we're at the 50% mark. Then we go across. He requires considerable assistance to walk. We go across, we see where it can be occasional assist. Oh, I'm sorry, I'm the wrong line. Considerable assistance required. So it's still under 50. And then it talks about he's otherwise fully conscious. Full, meaning full conscious, right? Because it's full or slash confusion. So he would be staged at 50%. So for example, 2, if a patient has become paralyzed and quadriplegic, requiring total care, so he's basically mainly in bed or totally bed bound, and he requires total care, we would stage him at 30%. And if you have example 3, if the same person was quadriplegic, he was bedbound, but he could perform some self-care or feed himself, then he would be a little higher, putting him at either 40 or 50%, because he can perform some activity. So with use, this is how we stage the patient, and then it can also help the pharmacist, clinician, to know how to, whether the medication needs to be, as I said, reduced to liquid form, etc. Then there's another scale, the global deterioration scale. This was used by my colleagues in their lectures before, and one of our colleagues went through this in great detail, so I won't go over it anymore. Basically, whichever stage a person is in, then you will know how to deal with the person, and also how you would facilitate medication. So going back now to deprescribing, this is a planned and supervised process of dose reduction or stopping of medication that may cause harm or is no longer providing benefit. Dr. Barbara Farrell is the author of this work, and she and her team, this and other information can be found at deprescribing.org. And in there, they have they've designed a guideline for this deprescribing. And this slide here goes over it briefly. If a person presents with, this is what a pharmacist would do, or a clinician. If the patient presents with their medication, you find out what is the patient taking this drug for. In fact, all of it. You look at the disease condition, what he was diagnosed with, condition A. Do you need to recommend deprescribing, whether dose reduction or removal of this drug? For example, if a person presents at the doctor, he took his medication within the right time frame, he tested the blood sugar, and for example, it's within the right range, and he's due another dose of the medication. The doctor would then, based on the results that the patient has been showing, that's why it's good to encourage patients to do like a daily blood sugar check and have the results recorded, so the doctor can see how well the medication is working or is not working, so that if it is working adequately, then we can be deprescribing. And then there are some conditions where you cannot deprescribe and you have to continue the drug. And if you do need to discontinue the drug, you taper it off. And during this process, you have to engage the patient, engage the caregivers to let them know what is happening, what is the intention, and the need for them to be giving you good follow-up so you can help monitor and manage the drug condition. Now, I must say, in Jamaica, Jamaicans are famous for always being proactive. And our clients, the patients, and the caregivers are very proactive. A patient came into me the other day and told me, me not give her this one, doctor. Cause after she can't swallow it, this one, she not need it, she not feel the pain. So you see, they are already deprescribing and helping to manage these patients. Of course, we have to advise them that they have to do it, you know, within the supervision of their doctor. But this person was actually dying. She had, I'm not sure, I can't remember what she had, but in the end, she stopped swallowing, and the lady would tell me that the pill is just rolling around in her mouth, so she not bother give up, you know, that type of thing. So those are the things that determine whether you continue giving the patient the drug. If the blood sugar is under control and the person is not swallowing the pills, you can move from, say, metformin to the injectables, but then you have to be careful because you need stricter monitoring with, for example, insulin, unless, of course, you use the arginine insulin. And then, of course, monitoring still needs to be done. So moving along in the whole paradigm of palliative care, you come to the end of life care and ethical considerations. Doctor went into the now accepted way of dealing with patients in that you do not use restraints. You withdraw the aggressive treatments. Artificial nutrition, artificial hydration, we have to, those have to be consulted with the patients and the caregivers. And so, in concluding, I'd like to just state that dementia and palliative care in the elderly present a challenge, but is a critical aspect of healthcare since it's now affecting so many people across all spheres of society. But because of the complexity of polypharmacy, we recognize the importance of this holistic approach to dementia. And palliative care goes beyond addressing cognitive decline and behavioral symptoms, but also to managing the intricate medication regimens that often accompany these conditions. And these are all aimed at improving the overall palliative care experience. So by supporting both patients, caregivers, and family members, we can significantly enhance the quality of life for those living with dementia. And I thank you for your time. And these are my references, along with the sites that you can obtain those tools. And thank you very much for your attention.
Wow, Winsome and I might have been the two speakers to stay within the time.
Well, you did.
Very,
You
very
did.
impressive.
Thank you. That's why I didn't do any cases for de-prescribing, because I figured it would have gone over, but yes.
Oh my gosh. No, but I thank you for that, because it's also a really great it's a great presentation. And I think that I always say, because people might not see it in that way, but I always say that dementia care really is a subset of palliative care. They are both. It's important for people to understand that even where a disease process may have what we might professionally call declining goals, where we mean that this person is not going to get better, we still do need to deliver care to the person, and care in a way that is appropriate and is not contributing to perhaps the patient's discomfort or dysfunction in any way. Polypharmacy is a huge topic. I think you covered that very, very well. Thank you so much for that presentation. What I would ask Winsome is, I say it a lot because I recommend clinical pharmacy a lot. I find there are a lot of people who have prescriptions that I think would benefit from being rationalized by a clinical pharmacist. For those of you and who will watch the recording as well, in Jamaica, pharmacists have the legal right in some ways to amend or substitute on prescriptions. But Winsome, my question is, how can the general public access you directly or access clinical pharmacists directly? I haven't had good results with it. Usually the doctors are very paranoid about the clinical pharmacist changing the prescription and them not knowing. Can you tell me how you would like that to happen? Should they ask their doctor, or can they come directly to you if they want to have their prescriptions reviewed?
Okay, well, they can come to have it reviewed. However, in Jamaica, we don't have the laws there for us to change anything without the doctor's consent and knowledge. So we can make suggestions, and then the doctor, so they can approach us and we can make suggestions, and we can call the doctor up and see what he has to say. But more than likely, he'll call them in and sort it out. But we can still give our input until the laws allow.
Yes, I appreciate that. Let me also, Winsome mentioned that we do have a talent in Jamaica for sort of taking medical matters into our own hands. So let me also repeat what Winsome said, which is that I would not recommend that anyone attempt. I mean, there's practical prescribing, like the person is not following it, but in terms of the person being prescribed medication, I would encourage everyone to seek the guidance of a medical practitioner and a clinical pharmacist or your pharmacist when you need to perhaps change. So instead of discontinuing, see if perhaps the medication needs to be changed. And if the state of the patient has changed, then you should inform your physician about that. I would just say those two things, which Winsome did say, but I'm repeating it because she's quite right. In Jamaica, we do have a tendency to take things into our own hands.
Yes.
So please remember to involve, if the condition changes, if your person is not able to take medication as before, please, update your practitioners about that change in status. It's very important. And then they can guide you accordingly. You can always consult a pharmacist where the doctor might not, as to whether or not, because some of the doctors, Winsome, I find, are not aware that there might be a liquid formulation of things available. So I always ask them to also check the pharmacist so that the pharmacist can say, hey, there is a liquid formulation for this, etc.
And also, yes,
Debbie,
if I might add to, thanks for those points, very salient point. If I might add to, not all tablets are to be crushed and made into liquid. So they can't
yes.
just crush it and put it in it. They need to consult because some of them have to be made from the injectable form. So they
Yes,
cannot be
yes, thank you,
crushed and
Winsome.
swallowed. So it's very
Thank you.
important that they don't just do, oh, she can't swallow, let me crush it. No, they need to find out from the pharmacist and let the
Yes,
pharmacist
please.
reformulate it for them.
Yes, and that's a very, very important thing to say, because again, as I said, we do tend to, it's on the spot, you have the medication already, but it can really alter the action of the drug. And as you said, I beg every client of mine, I beg them all the time, please, please, go to a pharmacist. If there's been a change and you're struggling to deliver the medication in the current form to the person that you're medicating, please discuss that with both your GP and or whoever the provider the medication is, and also with a pharmacist. I find them incredibly practical and useful. I can't say enough about pharmacy, and it's, it doesn't to me, none of the professions that I've showcased today really get the recognition they deserve in terms of how much they contribute, especially to the well-being of dementia patients and in palliative care, but just generally. Please consult. There are other professions other than the doctors who we love and respect. And I would always tell you, if you're having a doubt or there's been a change, involve your doctor and ask a pharmacist, please. Anonymous attendee who said this question has been answered live is not very helpful unless we have access to the recording. I will do my best to make sure that there is a link to the recording so that everyone can access it. Our intention is not in any way to provide a barrier to the access of this recording post the event. So, but if I answer it live, Zoom asked us to check it off so that I can clearly see the new question. Someone also said this has been eye-opening. Well done, and thank you. It's my pleasure, and I have to tell you the thanks goes to all of the participants, to Tanya, to Winsome, to Kartheka, who is coming all the way from the UK to talk, to Alexia, to Melissa. If these ladies did not participate and contribute, we wouldn't have anything here today. So we owe a great, great vote of thanks to all of the speakers who gave their time without any hope of remuneration, as we're paying them up front, that we had nothing to pay them or anything like that. And they still came and contributed and hopefully have raised awareness about the various aspects of dementia in Jamaica and palliative care. And Winsome, thank you for giving such a wider talk, because we do need to understand, as I said, that all hope is not lost because we have declining goals. You have choices, you have options, you have things you can do that are, really make a difference, especially in a person who might have some limitation on lifespan. You definitely want to make whatever time they have left count. So on that note, Dr. Christie, I thank you so much for being so patient. I will release you, and I'm also going to release everyone else from this webinar. Thank all of the participants who came at whatever time to listen in and to gain some knowledge. And we will, as soon as I have the Zoom link, I will make it available on all of my social media. So wherever you can find me on social media, you can have access to the link, and I'll see if I can also email it to attendees depending on what Zoom allows me to do. Okay? So everyone, thank you so much for hanging in there with me a little bit, quite a bit past time. Winsome, I'll let you go, and we're going to end this webinar now. Thank you, everyone, for coming.
Thank you for inviting me. I appreciate, enjoyed the whole thing.
Thanks, Winsome. You've been a blessing. You really have been. Everybody take care. Bye-bye.
Bye.